welcome to this great, wonderful webinar. Special thanks for our esteemed faculty from all over the world. Dr. Harvey Gutau, I think that's 100% sure that's not the real French accent, but one of the top French, I heard, like rigid bronchoscopy and other interventional pulmonary doctor from Marseille, France. We have Dr. Jamal doing pioneering work from Malaysia. I think he knows all our pulmonologists in India now in each state. I think welcome, Dr. Jamal. We have esteemed faculty, absolute top of the line faculty from all over the country, like Dr. Patavi from Coimbatore, Dr. Ravindra Mehta from Bangalore. In addition, a lot of fun too. Dr. Balraju Chadikonda from Vizag, Dr. Rajiv Goel from Delhi, Tinku Joseph as always from like Amrita, Kerala. So I think we have India well covered. All the top luminaries from all over and all over the world too. Like I know that because of this pandemic, this is a once in a lifetime pandemic, though in different stages in different countries. But we are coping with that well, and we congratulate everybody for attending these webinar sessions. I don't know when will we have our next scheduled in-person conferences, but in the meantime, though, we'll continue. We need to do our work, and we'll continue our good work through webinars. Just have a series of webinars, but this is a real high-quality webinar, and I am sure people will go much more enriched. Our team here in Yashoda, Hyderabad, a special thanks for the primary person I'll talk later, but we have Nagarjuna Matharu from Yashoda Somajigoda, been with us for ages, great work. Nagarjuna, we have Hari, our lead pulmonologist intervention from Second World, and our youngest and dynamic pulmonologist, other than myself, that is Dr. Vishweshwaran from Malakpet. Wonderful team, and in addition, we have Dr. Yugandhar Bhatt and Dr. Gaud from Malakpet team too. So thank you all for attending this conference, and this is a truly one of a kind conference, I think. So I was in the US and all. Fortunately, I'm not practicing pulmonary medicine now. I would not be able to do any of this stuff there. So, but now it's easy for me. Just we can say that I'm in management, looking after the finances. But you're doing great work. A series this presentation will go to multiple countries in addition to India too, all over people. This dissemination of knowledge from all over the world. This is a big change from the time I came from US and all. Before I went to US 10 years ago, I would have dreamt of these kind of things. We never had this, but now people from all over the world sharing their experiences, enriching people. I think we have a world-class faculty here, and I hope you have a great time for the rest of the conference. It will be followed by didactic sessions initially, slides and all, and then a more interactive question and answer session. Dr. Vishweshwaran will take a lead and guide this program. Thank you all from the bottom of my heart. Welcome, and I hope you'll go much more enriched. Thank you.
Thank you, Dr. Pavan sir, for the introduction. So today we will be having our interventional pulmonology virtual meet with the theme on central airway obstruction. So just to give an outline of the theme, so we will be having 3 talks, a brief talk by me on overview of central airway obstruction. Followed by that, we'll be having a talk by Professor Hervé Dutau on management of malignant airway obstruction. Followed by that, we will be having talk by Professor Jamalul Aziz on management of post-TB and post-intubation tracheal stenosis. And followed by that, we will have an excellent session on a case-based discussion, which will be moderated by Dr. Ravindra Mehta from Bangalore, to all our expert panel involving Pattabhi Raman sir, Rajiv Goel sir, and even Dr. Prashant Sharjat. and which will be, the cases will be presented by young eminent interventional pulmonologist. Followed by that, we'll be having a Q&A session. So to just start off the session, I'll be presenting an overview of central airway obstruction. So myself, Dr. Vishweshwaran, and I'm currently posted in Yashoda Hospital, Malakpet, and I'm working here as a consultant interventional pulmonologist. So before we move to the advanced things, what is referred to as a central airway obstruction? So any malignant mechanical obstructive process that impedes the airflow within the central airways, which involves the trachea or the mainstem bronchi and the right bronchus intermedius, we call it as a central airway obstruction. So the central airway obstruction can be in the form of a malignant, which may be a primary tumor of the trachea or the lung, or it can be a metastatic, the most common being the breast or the colorectal and the renal malignancies. Or it can be because of an extrinsic compression or a direct invasion of the adjoining intrathoracic malignancies. However, there are n number of causes for a non-malignant cause of a central airway obstruction. It can be in the form of lymphadenopathies or inflammatory disorders, the most common being the sarcoidosis and the virginous granulomatosis. It can be a vascular compression by means of a vascular ring or granulation tissue predominantly seen with post-intubation and post-tracheostomy, or even for that matter, a stent that was placed for a central airway obstruction. Or it can be a pseudotumor, it can be a hyperdynamic in the form of a tracheobronchomalacia or excessive pars membrana collapse, or idiopathic and very commonly seen in an ICU setting, it can be a mucus plug or even a blood clot. So when do you really suspect a central airway obstruction in a patient presenting to you? So most of the times these central airway obstructions can be seen even in an asymptomatic patient. So you need to have a very high degree of suspicion. It can present in the form of a cough, it can present as a dyspnea, hemopsis, or post-obstructive recurrent infections in the same site, or even in patient who has got asphyxiated, especially while taking a pill or any other foreign body. And any patient of a COPD where you have a refractory dyspnea and wheezing in a COPD or an asthma, then do always suspect a case of a central airway obstruction. So does all central airway obstruction mean significant? So not necessarily. When your endoluminal diameter is less than 50% of the normal, then it is an indicative of a significant airway obstruction. So we have a few textbooks which define that your exertional dyspnea related to tracheal central airway obstruction will not develop until your endoluminal diameter is less than 8 millimeter. And at rest, it will not occur until your endoluminal diameter is less than 5 millimeter. But this is actually a myth. There is no definitive numerical cutoff beyond which you will say that the patient will develop a central airway obstruction, significant central airway obstruction. So let's move on to what that determines the dyspnea in these patients with central airway obstruction. So it depends upon your degree of obstruction. It depends upon your muscle strength. For example, a very frail patient will not be able to compensate for the increase in the workload. That it can be determined by your compliance of the chest wall and the elastic properties of the lung, the metabolic demand of the patient, which will increase the work of breathing, or the acuity of obstruction. Like example, a foreign body can present with a sudden onset central airway obstruction, the degree of the post-obstructive atelectasis, even the severity of the underlying pulmonary, cardiac, and the renal diseases, and even pain and anxiety. So there is no particular numerical cutoff with which we can say that the patient will develop a significant central airway obstruction. So there are various diagnostic modalities. The basic one which we use is a chest X-ray. But the advantages is it can be used for a patient who are not able to lie for an axial imaging. It can be used for a rapid post-intervention comparison for lateralizing the pathology, and the lateral radiograph can be used when you have which will provide a less obscured evaluation of the trachea. But the limitation, as we all know, the mediastinal and the bony structures, and many a times the central airway obstruction gets missed in your X-ray. So next comes the chest CT, which is considered to be the imaging modality of choice. It provides a 2D and a 3D rendering. It helps in the estimation of the lesion length, the degree of the airway narrowing, the anatomical relations to the structures surrounding the airway. And one advantage is that you can have a 3D reconstruction, which we call it as the virtual bronchoscopy. So it will give you even an idea that what is the extent of the obstruction and what structures are there beyond the site of the obstruction. So this is just an image that shows how a 3D reconstruction is done. For example, here we can see a stenosis of the left main bronchus. It gives an idea about the degree of the stenosis, the length of the stenosis, and what is the distal segment and how effective the distal segment is. But however, is CT the gold standard? No, definitely not. So here we have a study, which is a retrospective review of pre-treatment chest CT in 42 patients who eventually underwent therapeutic bronchoscopic intervention for central airway obstruction. And as we can see that the radiologists failed to identify central airway obstruction in 31% of studies. So this means that your CT is not the gold standard. And if you have a high suspicion of a central airway obstruction, even with apparently a normal CT, you may have to go for your bronchoscopy. So the other diagnostic modality is pulmonary function, which though quoted in the literature in most of the times, not so often used in a interventional practice for diagnosis of central airway obstruction, because these patients generally land up to you in an emergency setting where you do not have a time to do this pulmonary function test. So it can be in the form of the first figure on the left side shows the presence of a fixed airway obstruction, while the second image shows an intrathoracic obstruction, while the third image shows an extrathoracic obstruction. So then comes the role of the diagnostic bronchoscopy. The advantages are it will help you to confirm whether there is a central airway obstruction. It will help you to assess the length and the diameter of stenosis. It will help in the biopsy for histopathological diagnosis, the planning for a therapeutic procedure, and even in removal of secretion in an ICU setting. But limitation is when you are dealing with an unstable airway, you may precipitate an airway edema and you may convert a non-significant central airway obstruction to a significant, and patient may land up in ventilator. So be careful when you handle diagnostic bronchoscopies in these patients, and bleeding is always a risk and always a part of your interventional pulmonology practice. So these are the few images which shows how your bronchoscopy helps. The first picture on your left side shows the endoluminal obstruction. The second one shows an extraluminal compression, and third one is a mixed form of an obstruction where you have both an intraluminal and extraluminal component. So it can help in identifying. It will also help you in triaging your resources for the management of these patients. And these are various images. The first one on your upper panel shows a post-intubation tracheal stenosis. The next one shows a granulation secondary to the stent, and we have a tracheosteopathica chondroplastica. And on the lower list, we have the idiopathic stenosis, solitary papilloma, and papillomatosis. So this is just to say that your central airway obstruction is not always due to your malignant process. It can be due to a lot of benign causes. And in a TB endemic country like India, your tuberculosis will always remain a part of your central airway management algorithm. So thank you. I just want to introduce our next speaker. Our next speaker will be Dr. Hervé Duthau. Dr. Hervé Duthau is the head of the thoracic endoscopy unit, a thoracic oncology, pleural diseases, and an interventional pulmonologist in the North University Hospital, Marseille, France. Sir, please, you can upload your slides.
Thank you, Visves. And by the way, you pronounce my name well, because it's Duthau. Yes, in French, A and U sounds O. That's great. You see it? You see my presentation? Yeah? I don't hear.
Not yet. You need to share your presentation.
But it's on the screen. What? Ah.
You need to press the share screen button.
Okay. I see here. And now, yes. You see?
Yeah, we can see it, sir. Yeah.
So, okay. Again, thank you very much, Visves, for your presentation, your overview, your invitation. It's nice to see again my friends, Patabi, Ravi, and all of you. So I will speak about the management of malignant central airway obstruction, and I will, I would say, avoid the endless and useless discussion about which techniques to use. Do we have to use thermocoagulation? Do we have to use laser? Do we have? I think these are useless controversies. The most important is the result at the end. Whatever the technique you use is the result you get. So I will probably repeat some of your data, Visves. And the first one is that malignant airway obstruction is a frequent situation. In the past, it used to happen in 30% of people presenting with lung cancer. Now you see it has decreased to the last publication from my friend, David Breen from Ireland, has seen only 14% of central airway obstruction with lung cancer. And this is probably due to a shift from the central squamous cell carcinoma to more peripheral adenocarcinoma since the last decades. Different kind of smoking. But by the way, it's still a frequent situation because lung cancer is still, at least in France, is the first cancer for men and for women. So it's a frequent situation for us. As you said, this vest, it can present as a endoluminal obstruction, eccentric compression, or sometimes mixed compression. The fact is that these people suffering from that have a reduced survival, very bad quality of life, and above all, this kind of obstruction can jeopardize oncologic treatment like chemotherapy, radiotherapy, because of respiratory failure, infections, atelectasis, that can prevent radiotherapist to focus on the tumor. And talking about oncologic treatment, we know from the literature is that if you expect chemotherapy or radiotherapy to relieve compression and quickly relieve compression, then you know that it won't work. Or at least in only 20% of cases, you can reopen an airway compressed or obstructed by a tumor. So, as interventional pulmonologists, we have a real role to play in the management of lung cancer, and we can palliate obstruction at each step of the disease. It can be neoadjuvant, and that's very interesting because last year we've started a French registry regarding rigid bronchoscopy in obstructive lung cancer. And one of the first data which interested me is that therapeutic bronchoscopy is the first treatment of lung cancer in 30% of people. So that means they enter the disease with dyspnea, sometimes distress, and the first treatment of lung cancer will be therapeutic bronchoscopy. So that's very interesting to know. At least in France, that's a reality. Then, of course, it can be adjuvant treatment in parallel with oncologic treatment, and unfortunately, it can also be palliation when all oncologic treatment have been exhausted. Again, I won't go too much into detail, but the techniques we use in Marseille, so the people who came to Marseille know it, is mechanical debulking, but in Marseille it is laser-assisted mechanical debulking. And you see here the different step of this obstruction. You see first picture A, a tumor obstructing the trachea, then a tumor devascularized with laser. On figure C, you see the coring with a bevel bronchoscope. Then on figure D, it's a removal of a large piece of tumor with a rigid forceps. On E, you see the tumor. And the last step, figure F, will be the coagulation of the basis of the tumor. This is something that can be achieved very fastly, quickly, and safely with a rigid bronchoscope. And it lasts only, no more than 30 minutes. Therapeutic bronchoscopy, which are the expected results of that? You can expect immediate debulking in about 90% of the cases, lung function improvement, benefit duration. Benefit duration is lasts only 3 months before recurrence or local recurrence. Survival improvement is probable because there is nothing in the literature, no evidence-based medicine, because there is no comparative study between I debulk, I don't debulk, because it is clearly not non-ethical nowadays. And you, of course, you reduce the risk of respiratory failure with a vital risk of the procedures in the literature, roughly 0.3 to 2.7. Stenting will be proposed in case the main indication is excessive compression, because when you have excessive compression, you cannot debulk, you cannot core anything because it's behind the wall, or obstruction of more than 50% after debulking of the interesting part of the disease. We have plenty of data in the literature stating that you have a clinical benefit of that. You improve lung function, but again, lasts only 4 months before the stent itself can be invaded by the tumor, either on the proximal edge or at the distal edge. I don't know if I have time to show you the movie. I can this was, or a movie of what can be done. It's interesting because it's a movie recorded by Dr. Dumont, well, a few years ago, but it's still actual. You see here the bevel of the rigid bronchoscope, here, and you see the effect of laser. So laser, in Marseille at least, is used with low power settings. The aim of laser is not to vaporize the tissue, but it's to prepare the tissue to mechanical coring. In fact, we don't use laser with high power settings because, well, vaporization can be dangerous. You can eventually perforate the wall and make fistulas. So laser is only used to assist mechanical coring. So once devascularization is deemed acceptable, then the coring is performed. You see the bevel of bronchoscope follows the bronchial wall and core a big piece of tumor that can be removed using the suction catheter like this. Once the internal part of the endoluminal part has been removed, then laser can be used to coagulate the tumor. Here there is a middle lobe and here is a lower lobe. And because the lumen was less than 50% the stent is placed, here is silicone stent. And so in the whole procedure, you reopen and you can place a stent for long-term duration of reopening. Here the stent is reopened with using a balloon dilation. Well, this is an example of what can be done with rigid bronchoscope, stent, and laser. Maybe you can think that I'm a bit biased because I'm in Marseille, I've been trained by Dumont, but I'm not the only one stating that rigid bronchoscope is very useful for the management of central airway obstruction. Here a study by Mahmoud and all, Respiration 2015. You see clear clinical improvement in this prospective study in lung function data, dyspnea, and quality of life with maximum safety and using silicone stents. I don't know if Prashant has joined us, but this is a very important study that he published in 2006. And he showed that if you compare a group with the same stage of the disease, group A with a treated central airway obstruction, successfully treated central airway obstruction, if you compare to patient without central airway obstruction, so if you are able to successfully debulk, then you offer the patient the same survival curve, which is in fact not very nice, but it's the same with or without central airway obstruction. But the question I have now, again, it's not about which technique to use, but it's about the prerequisite for a successful procedure. We already know that you need several items. First, as you mentioned, Visves, is a proximal obstruction. Proximal obstruction is trachea, mensa bronchus, bronchus intermedius. The disease has to be localized. Localized, that means that behind the obstruction, you have to have functional bronchi and lung parenchyma behind the obstruction. It's very important that to add that you need a functional pulmonary artery. Otherwise, you can the ratio between ventilation and perfusion could be wrong. And the last point would be performance status enough to enjoy the clinical benefit. I mean, if you propose this obstruction to someone with PS4 on the bed 100% of the time, then I think it's useless. And something that I didn't say, I didn't write, it's very important, is that to recall that it is symptomatic treatment. Symptomatic treatment means that you need symptoms to propose this obstruction treatment of central airway obstruction. And as you said, this is mainly dyspnea. Dyspnea is probably the main symptoms that we have to focus on. So, in other words, when we have this kind of chest X-ray with a complete atelectasis of the right lung, is it the good situation here where you have localized disease, central airway obstruction, with safe bronchi and probably safe parenchyma behind, or this situation where what you see in your bronchus is just a visible part of the iceberg? So can we predict that we will be successful with our therapeutic bronchoscopy? So, and that's very important because when you look at the registry, American registry, there is a huge gap also between the technical success, and you see in this publication by David Ost in CHEST 2015, the technical success was deemed successful. I mean, it's in 93% of the cases. But when you look at the clinical improvement, then it dropped to 48 for the symptoms and 42 for the quality of life. So there is a difference between stating that you're successful, technically successful, but sometimes you can also be clinically not successful. And it's important to consider that. In my practice, I have individualized different kind of predictive factors. You have the clinical data, imaging, and endoscopic aspects. Again, symptoms are very important, and dyspnea. One very important clinical predictive factor is acute or subacute dyspnea. That means that you have a sudden obstruction of the proximal airway. So that means that behind that, you used to have the presence of functional bronchi and parenchyma behind. Unlike this progressive dyspnea, which generally represents an obstruction from the distal growing to the periphery, to the proximal airway. And of course, in case of absence of dyspnea or only on exertion, there is probably, again, a progressive obstruction coming from the periphery and generally associated with a pulmonary artery constriction or invasion. When you look at a paper from the Belgium group from Mark Noppen, where they enrolled 24 patients, all successfully debugged, you look at the Borg score before and after, and you see that most of the patients who improve have a high Borg score before the therapeutic bronchoscopy. Recently, we published, it was in 2020 in Respiration, the first prospective and randomized study regarding therapeutic bronchoscopy, which is called SPOC study, Silicone prosthesis in hospital lung cancer. It was a prospective, again, study granted by the National French Cancer Institute. 9 French university centers included 78 patients. So the question was, we do a therapeutic bronchoscopy for primary lung cancer. We are successful. That means that we have more than 50% of the lumen after therapeutic bronchoscopy. And then we have randomized patient onto a group with stents and a group without stents. The question was, do the stent has a barrier effect that prevent local recurrence and hopefully quality of life? But of course, you expose patient to stent-related complication, and you're in the other arm without stent, so no stent-related complication, but maybe higher frequency of recurrence. So here is the algorithm, central airway obstruction, informed consent. Then first step was tumor resection with rigid bronchoscope, and inclusion was confirmed on the operating room if final diameter was more than 50%, and all the tumoral segment could be entirely covered by the silicone stent. Then randomization, stent or no stent. And again, a clinical follow-up, 3, 6, 12 months, in parallel to the oncologic treatment. So the main endpoint was at 1 year survival without local restenosis. Unfortunately, we have not been able to answer this question because we have not been able to enroll enough patients. But we have been able to answer to a secondary endpoint: survival, quality of life, restenosis rate, and tolerance of the stent. What is very important, because in this group of 78 patients, we only have successfully debulked patients, only successfully debulked. And when you look at the Borg scale before the inclusion, it's about 6.5. So it's a very important dyspnea before treatment. And after, it dropped down to 2.5. So 4 points, which is very important. And unfortunately, with time, dyspnea gets back. One of the most important message of this study is that if patients are naive from any oncologic treatment, like never received chemotherapy or chemotherapy plus radiotherapy, the benefit for placing a stent is not present. But in case of failure of a first-line chemotherapy, then there is a very important benefit for placing a stent. So, which is somehow logical, because a naive patient can undergo treatment and hopefully expect results from oncologic treatment. But after failure of a first line, then the chance of having response with oncologic treatment is very low. So a stent is useful. This is the conclusion of a Spock study. Therapeutic bronchoscopy improve for long periods the quality of life. Barrier effect of silicone stent is obvious and delays the restenosis of about 3 months. And again, no effect on patient naive from oncologic treatment. And tolerance is very good. So we can recommend from this study to insert a silicone stent in patient after efficient debulking in case of failure of a first-line oncologic treatment. Now about imaging, predictive factors. Absence or recent atelectasis. Recent means that you have a previous imaging which shows that there is no obstruction, and I would say 1 month after, 2 months after, then you have atelectasis. That's a very good factor, because that means that you have a safe airway behind the obstruction. You see on the CT scan here that is free above and behind. In case of atelectasis, CT can help, of course, to differentiate the tumor, to see blood vessels in the atelectasis, eventually a bronchogram. You can see aspects which are not very good factor, but predictive factors such as carcinomatous lymphangitis. And you also can see if there is compression or invasion of the pulmonary artery. CT scan also can be useful, but it's sometimes difficult to have it in emergency. But in case of atelectasis, you can, with a TEP scan, PET scan, differentiate tumor and atelectasis. Now about endoscopic aspects. Three items: tumor implantation, the airway beyond the tumor, and the localization of the tumor. From my practice, it's of course easier to remove endoscopically a pedicular lesion compared to a large basis. And of course, when you have a spread distally disease, it's even more complicated to expect a good result. How to have an idea about the distal airway behind the tumor. Here you have a tumor obstructing the right lower lobe, and you see just with the suction catheter you can palpate the lesion, try to consider where is the basis, and eventually pass behind. And when you see that there's a pus coming in transparency in your suction catheter, that's a very good predictive factor to have a safe bronchi behind. Other things that you can do is with a flexible bronchoscope, try to pass behind, inject saline, and try to open the airway and to see if you have a safe airway. Now about the localization of the tumor according to the location. This comes from ancient studies from Dr. Dumont, and it's again logical to see that more your proximal, trachea, right main bronchus, left main bronchus, the better are the results. And of course, when you go distal and above all with in the upper lobes, left and right, then you have bad results. So Dr. Dumont used to say that it's because you cannot access upper lobes with a rigid bronchoscope, which is, in my opinion, not only the main reason of the bad result. In my opinion, more you go distal in lobar obstruction, less you have a chance to have safe airway behind, safe parenchyma, and generally, just a lobar obstruction is not that symptomatic. So you cannot expect dramatic improvement just by reopening a lobar obstruction. Just a case, very good case, case one, just to show you the good case, I would say. On the X-ray, you see that right hilar was a little enlarged. You see clearly on the CT scan that there is a tumor coming from the right upper lobe, obstructing the bronchus, right main bronchus and bronchus intermedius, and behind it's free. So this is clearly one of the perfect case for therapeutic bronchoscopy, because you see, like in this case, you don't even have to do laser because it's already necrotic in surface. So you just core, remove, and it's done very quickly. Big piece of tumor. Oncologists, pathologists are very happy because they don't complain about the little size of the samples. And at the end, you just have to do laser on the basis of the tumor and you reopen the airway. So that's a very good case. Another case, you see a patient, 2013, yes. Patient with not very high dyspnea, only slight dyspnea. You see the CT scan, already in this slide, you see that left main bronchus is obstructed somewhere, but not proximally, not that proximally. When you look at the other slide of the CT scan, you see different things. You see that the pulmonary artery is completely obstructed, compressed. You see that the heart is even invaded here. So clearly, even before going with a bronchoscope, you can you can predict that this case won't be a very good case for therapeutic bronchoscopy. PET scan shows, by the way, that the tumor is quite localized, but again, invading the heart here and compressing the pulmonary artery. And so, not surprising, it's all invaded everywhere. You have no safe bronchi, no safe parenchyma behind the obstruction. So this patient is not amenable to successful debulking. So in conclusions, predictive clinical factors for successful disobstruction exist, but there is no publication in a prospective way to answer properly to the question. Wood would say that you have to be clinically meaningful and you have to do it if it's clinically meaningful and technically feasible. That's a nice sentence, but in daily practice, I mean, except in case of obvious, like the cases I just showed you, obvious failure of therapeutic bronchoscopy, in some cases you have to try and see if you can do something. But again, I think that most important is you have to consider only very symptomatic patients or moderately symptomatic patients. We still have questions regarding central airway obstructions. Even in 2013, in the ACCP, Mike Simoff wrote that in lung cancer with inoperable disease and symptomatic airway obstruction, you can propose therapeutic bronchoscopy with medical debridement, tumor ablation, airway stent placement, and you can improve dyspnea, cough, hemoptysis, and quality of life. But again, grade is 1C. Question is about the real technical success rate. And you remember the gap between the percentage of technical success and clinical improvement, the timing of airway stenting. Now with the SPOC study, we have a part of the answer, not in naive patient, but after failure of of chemotherapy. I have to point out that the study was done with chemotherapy, and maybe the answer can be different with a new treatment of lung cancer with immunotherapy, individual treatment. The survival benefit related to stenting is not completely clear. I think one thing is clear now is about improvement of symptoms, parametry, and quality of life. So this is probably my last slide. Before I remind you that this year we have a World Congress for International Pulmonology, but you know that in China we could not go. It will be in November. It will be presential for Chinese people, but for non-Chinese, we'll have to do like we do now with webinars. But in 2022, the COVID will be far behind us, so you have no excuse if you don't come to Marseille. I showed you the view we have, so there is no reason not to come to Marseille in 2022. I will have a chance to be co-president with my friend Professor Astoul. So I hope I will see you in 2 years now. Thank you.
Thank you, Professor Hervé Dutta, for an excellent talk. So we'll be moving to the next talk by Professor Jamalul Aziz. Dr. Jamalul Aziz is working as a consultant pulmonologist at Serdang Institute, Malaysia. And Sir will be speaking on post-intubation and TB airway stenosis.
Thank you very much. I would like to thank Yashoda Hospital, Dr. Pagan, Dr. Arun for inviting me to give this talk. It's good to see familiar faces here from India, and obviously my mentor, Dr. Hervé, whom I met in Marseille in 2007. So my talk is on the management of benign airway stenosis. I'll be focusing in post-TB and post-intubation airway stenosis. I won't be able to complete my talk without showing these photos. Dr. Dumont there, or Professor Dumont there, obviously, who inspired me to take up rigid bronchoscopy, and obviously Dr. Hervé at the bottom there, whom I met in 2007, Dr. Hervé. And the Ravindra Mehta was there also with me. Dr. Green, Dr. David Breen from Ireland was there. And then our colleague from Morocco or Tunisia, I can't remember now. Next. So these are the objectives of my talk: to examine the current management option for benign airway stenosis, identify patients who may benefit from surgical versus endoscopic options, and evaluate the current literature supporting the management options of benign airway stenosis. Next. So there are many causes of benign airway stenosis already covered by Dr. Arun. So I'm just going to focus on post-intubation and post-TB stenosis. Next. So in terms of the management of benign airway stenosis, I think we need to evaluate the underlying etiology, whether it's from infection such as TB, is it related to a systemic disease such as vaginous, or related to previous trauma such as intubation. We also need to evaluate comorbidities and the ability of the patient to tolerate procedures. Next. But the question is, in our mind is always, what is the best management for benign airway stenosis? Is it surgery or is it endoscopic approach? So, and then you see that the endoscopic approaches, we have stents and bronchoscopic dilatation. So this endoscopic approach meant for as a bridge to curative surgery or palliation if the patients are unsuitable for surgery, or are they for restenosis that occurs after surgery? So these are some of the questions regarding the best management for benign airway stenosis. And then we also need to qualify the population, likely that we are going to focus on patients with non-systemic diseases such as TB and post-intubation. And then what does the literature say? Well, the surgery is always the gold standard, but does it really say that? Next. So surgical resection is always considered the gold standard. However, it's actually reserved for those who are eligible for surgery. But the downside is it is uncommonly performed, and it is highly technical with significant post-operative care requirements and management, and it is likely dominated by a few major referral centers in the world. Next. And just to share with you my experience with regard to surgery in the post-TB stenosis, chest X-ray number 1 there was the first presentation of a young female with left lung collapse secondary to post-TB in 2015. And then we did dilatation and we put a silicone stent there. Left lung re-expanded, but the patient couldn't tolerate the silicone stent, and the patient was referred to our thoracic surgeons for sleeve resection, and she underwent sleeve resection, but the left main stem stenosis recurred, and then on chest X-ray number 3 there showed that what it looked like after we did laser to open up the stenosis, and then 2 years post laser, the left lung remains aerated without any intervention in the last chest X-ray there, and the patient is well. So what about stent in benign airway stenosis? I know that Marseille does a lot of stent by Dr. Hervé. So we know that stent can relieve airway obstruction, stent can provide immediate relief of respiratory distress or failure, but stent can cause complication and can be very difficult to manage. And just a word from our friendly surgeon, silicone stent or expandable stent, even if coated, appear inadvisable to treat benign airway stenosis. And they feel that stent should be used only when curative surgical interventions are not feasible or are contraindicated. Next. So what is the problem with evidence-based intervention pulmonology or airway disease? So the problem is most of the literature is case-based and retrospective, and designing and executing randomized controlled trial in interventional pulmonology can be difficult because of ethical concerns and selecting patients with comparable comorbidities and disease processes and double blinding procedures can be difficult. Next. So just look at this paper from BMJ in 2003. So what about parachute? So we know that parachute can reduce the risk of injury after gravitational challenge, but their effectiveness has not been proven in randomized controlled trials. So just because there are no randomized controlled trials in parachute doesn't mean that we shouldn't be using parachute to prevent death. Next. So the first part of my talk is about post-TB airway stenosis. I'll try to fast forward in the interest of time. So I think post-TB stenosis is well known in this part of the world, in India, in Malaysia. So I think there's nothing very new about the facts about post-TB stenosis. We know that most of the TB cases can be cured by appropriate medical treatment, but sequelae and complication can happen, including airway stenosis. Although in the West, benign stenosis of the airway is often iatrogenic, such as prolonged intubation, but in TB endemic countries, endobronchial TB is a common cause of airway stenosis. Next. And again, I think there's nothing new about this slide. If you are working in India or Malaysia, endobronchial TB is something that we face. And this picture just shows the fibrostenotic type of endobronchial TB. Next. And just to show the many types of endobronchial TB, the classification by our friend from Korea, from the caseating type to the tumorous type, the bronchitic type. So I don't do flexible bronchoscopy routinely in patients who are smear positive. So I don't see this kind of appearance in Malaysia. But this is one of the classification of endobronchial TB. Next. And then, so who are at risk for endobronchial TB? In Malaysia, my personal observation, young female and those with longer symptoms duration, more than 4 weeks. Next. So post-TB stenosis was first described in 1689, and it is under-recognized and is often misdiagnosed, sometimes misdiagnosed as asthma. And stenosis can develop many years despite adequate anti-TB chemotherapy. And steroid has no influence in terms of outcome of endobronchial TB. Next. And the left main bronchus is the commonest site. It's also based on my observation in Malaysia. And unlike post-intubation stenosis, post-TB stenosis can involve both the trachea and bronchus, making management very, very difficult. And therefore, early diagnosis is important to control obstructive symptoms. Next. So they just, okay. And symptoms, I don't have to repeat these. We all know the symptoms of airway obstruction, central airway obstruction, wheezing, stridor, dyspnea, recurrent pneumonia. Next. In terms of imaging and diagnosis, I think we are all familiar with the diagnostic test, chest X-ray, and then normally we do followed by 3D reconstruction of the CT scan to establish the dimension of the lesion and to assess if the airway distal to the lesion is patent and the relationship to other structures like vessel. And generally, we will do flexible bronchoscopy as the next step to help in the planning for further intervention. Next. So the treatment for post-TB stenosis, again, surgical resection and reconstruction is the preferred therapy for post-TB stenosis, but we know that not every patient is eligible for surgical resection. Patients may refuse, and then the anatomical limitations, long segments, Malaysia, severe stenosis, and multiple level, poor lung function, and then complication of surgery, such as anastomotic leakage, requiring re-anastomosis, and then re-stenosis even after surgery. Next. So what are the non-surgical options? Next. So the indication for endoscopic intervention, again, the obvious symptoms, dyspnea, post-obstructive pneumonia. Next. And should we wait until the patient is smear negative before we do intervention? Well, I think if possible, we can wait until the patient is smear negative, unless the patient present with life-threatening central airway obstruction, in which case we will have to go in regardless of whether the patient is still smear positive or negative. Next. So these are the endoscopic approaches in the management of post-TB stenosis. As you can see there, there's nothing unfamiliar to us, I think. Balloon dilatation, mechanical dilatation, mitomycin C. After dilatation, some people don't believe in it. Stenting and laser. Next. Just to show, just to show the video, a short video. Again, there's nothing new about this technique, balloon bronchoplasty for post-TB stenosis. The balloon is inserted through the side port of the rigid bronchoscope. Next. And then mechanical dilatation. One of the cases that we did in my place, post-TB stenosis, I think after balloon bronchoplasty, we did mechanical dilatation. Next. And then what about recurrent? Yes, recurrent is not uncommon after dilatation. And so what do we do to prevent recurrent or to slow down the onset of recurrence? So this is my practice. Again, nothing unusual about this. I apply mitomycin C, and in some cases, if mitomycin C doesn't work, I'll put a silicone stent if that is possible. Next. So what is mitomycin C? It is an antineoplastic agent that inhibits fibroblast proliferation and development of granulation tissue. It has been shown to have some benefit in delaying recurrence of post-intubation tracheostenosis, but its use in post-TB stenosis has not been well described. Next. So again, this is just to show how we apply mitomycin C after dilatation. Next. Okay, just to show a quick video, one of the cases that we did 3 years ago, post-TB stenosis, we did dilatation, and that was followed by mitomycin C application. Can you fast forward the video, Harry, just to save time? Yeah, so that's just to show mechanical dilatation, and then fast forward, okay, and this shows the mitomycin C application. So nothing, nothing extraordinary about this. Next. Okay, just to share with you one publication, just a case report. One of the cases that we did successfully. It's a multi-level post-TB stenosis, actually, which we managed to manage with balloon bronchoplasty followed by topical mitomycin C without putting a stent. Next. So what about stent? So sometimes I'll put a stent in TB stenosis if mitomycin C doesn't work, or if there is presence of airway Malaysia. Next. So there are a few types of stent. So we know that Professor Dumont introduced the started silicone stent in 1990. So we have silicone, metal, and hybrid stent. Next. So what are the advantages and disadvantages of silicone stent? You can find this in any IP textbook. So I think the main thing about silicone stent is the need for rigid bronchoscopy to deploy the silicone stent. Next. So the timing, in terms of timing of silicone stent removal in post-TB stenosis, I think more or less we are talking about between 6 to 12 months. Next. Just to show a short video of a case of post-TB stenosis where mitomycin C didn't work, so we had to put a stent. So you can fast forward the video, Doc. This balloon bronchoplasty. Can you fast forward? Yeah, so lumen restored. Fast forward. Can you fast forward, Doc? Yeah, that's the stent that we deployed. Quite challenging to deploy the stent in the left bronchus. Perhaps for sure, the Prof. Hervey can do a better job than me. So this is what we did to unfold the stent in the left bronchus. Can you just show the end product, Doc? Right at the end there, can you fast forward? So we had to use a balloon unfold the stent. Fast forward, Doc. Yeah, so ultimately we managed to unfold the stent there. Fast forward a bit more, just to save time. Yeah. So in this case, we use a balloon to unfold the stent. Okay. Next. Okay, so laser, just a few case report on laser in post-TB stenosis. To me, I think it is a complementary therapy and it's not recommended to be used alone. So it probably has to be used in conjunction with balloon bronchoplasty and balloon bronchoplasty. Next. So this is the publication on laser in post-TB stenosis, showing the improvement in the lung, in spirometry, the flow volume loop before and after laser. Next. So what about the outcome using the endoscopic approach in post-TB stenosis? This is a paper published by Professor Philip Eng from Singapore in Journal of Bronchology many years ago. So he had 21 patients in this paper. So 14 patients had only one procedure, and then you can see the outcome there. Half of them remained asymptomatic, but some remained symptomatic. 2 patients had 2 procedures and had restenosis. 4 patients had 3 procedures, and 1 patient even had 5 procedures. So in terms of the outcomes, it looks like maybe perhaps the majority had good outcome, but some some developed complications, some required pneumonectomy, and some remain symptomatic. So it seems that the result is mixed. Next. What about my own experience, unpublished data, just a small series, 7 patients, we put stent in 4 out of 7 patients. So, and one of the stent migrated. But the outcome, 4 of them had patent left main bronchus, but some continued to have recurrent stenosis, and one of them even had 5 procedures, and we even plan to put a stent. Yes, and so we had some success, but we had some failure as well. Next. So that's about post-TB stenosis. Now I just going briefly about post-intubation stenosis, which mainly affect the trachea. So again, post-intubation stenosis is due to the use of high pressure, low volume cuff endotracheal tube, and so now our practice now is using high volume, low pressure cuff endotracheal tube. But in spite of that, post-intubation tracheal stenosis is still not uncommon. So this is what it looks like. The endotracheal tube that we use, the high volume, low pressure, and this is the old one, the low volume, high pressure endotracheal tube, which causes tracheal ischemia and necrosis, leading to post-intubation tracheal stenosis. Next. So again, the treatment, whether surgical or endoscopic, in my opinion, needs a multidisciplinary discussion involving pulmonologists, thoracic surgeons, and ENT. The mainstay treatment remains surgical, but it is not without risk, just like in post-TB stenosis. And the fact is that surgery cannot be performed in all patients, and that one we know. And again, the endoscopic methods may be the only alternative if the patient are not eligible for surgery. And the endoscopic methods are familiar to us: rigid dilatation, mitomycin C, laser, plus minus stent. And relapses are not uncommon. Next. So what do we do? I think to me it should depend on what I see, whether it is the stenosis in the trachea, whether it is subglottic. If it is in the subglottic area, I don't intervene. I will leave it to my ENT surgeons to intervene. And whether it is web-like or complex tracheal stenosis. So I tend to manage simple tracheal stenosis. The complex ones will be discussed in our MDT meetings involving thoracic surgeons and pulmonologists, as well as ENT surgeons. Next. So surgical comments on post-TB, post-intubation tracheal stenosis, about stents. So this is what the surgeons say. Rarely would a silicone stent be considered as a bridge to resection, and never should an expandable stent be considered at all. And tracheal reconstruction procedure should not be undertaken without considerable study and experience. So the word here is considerable experience. So we know that there are not many centers in the world, I think, that perform tracheal reconstructive procedures. So I think it's not easy to gain considerable experience. And what about silicone stents? Again, silicone or expandable stent, even if coated, appear inadvisable to treat benign stenosis, since they not only produce severe stenotic lesion, but may make future definitive repair impossible. So these are words from our friendly surgical colleague. So what about the data regarding tracheal resection? I just got this paper on anastomotic complication after tracheal resection. I think one of the centers in the US. It was a retrospective review, data from 1975 to 2003. It is a large international referral center for tracheal disease. They perform 22 cases per year. And looking at the complication here, the one that I highlighted in the rectangle there, the post-intubation tracheal stenosis, the complication there, overall 18.5%, anastomotic complication 11%, and low mortality there, 8 patients there. So in terms of predictors of anastomotic complication down there, in table 4, the length, whether the patient had preoperative tracheostomy, young age, diabetes, reoperation, and laryngotracheal resection. So I think overall, the result of tracheal resection are acceptable in terms of the complications and mortality. What about data for bronchoscopic treatment for benign tracheal stenosis? Just going down in table 2 there, type of stenosis, simple stenosis there, the cure rate is almost approaching 100%. And for complex stenosis, it is almost 70%. And looking at the type of endoscopic treatment choices used there, I think there's nothing unusual about the procedure there. I think we all do these procedures routinely: rigid bronchoscopy and debulking, flexible balloon dilatation, APC, laser, cryotherapy, stent, even mitomycin C application. All right. So overall, in this paper, it seems that endoscopic approach is an acceptable technique in the management of benign tracheal stenosis. Next. So just to show my own work, although it was just a case report many years ago, we published our work when I was first starting rigid bronchoscopy, successful treatment of tracheal stenosis by rigid bronchoscopy and topical mitomycin C. Next. Yeah, if you can, Doc, you can show the play the video. Next. Okay. No, the next one. No, the one before. Yep. At 12 months. Yeah. So this is the end result. At 1 year, the tracheal lumen remains patent, and you didn't need to put a stent. Next. However, mitomycin C doesn't always work. Just to show you, one of the cases, post-intubation tracheal stenosis, we had to put a stent because the stenosis recurred even after we put mitomycin C. Just to show you. So to me, putting a silicone stent is always a very challenging procedure. So in this case, we managed to put a stent. Yeah, successfully. Yeah. Next. So my last slide. So I think in summary, a number of endoscopic options exist for benign airway stenosis, but in my opinion, no single technique is satisfactory, and all these endoscopic approaches are palliative, and they tend the stenosis tend to recur, and patient need repeat sessions. There are complications with stents, and but sometimes these endoscopic approaches may be the only alternative in patients who are not suitable for the gold standard curative surgical resection. And I think patients who have complex airway stenosis should undergo. The cases must be discussed in a multidisciplinary approach. In the evaluation of surgical versus non-surgical management option. And then I think the mechanism of obstruction, the extent, location, morphology, etc., these are factors that determine the need for surgical or bronchoscopic intervention. And I feel that we still need to find better techniques to manage benign airway stenosis. Thank you very much.
Thank you, Dr. Jamalul Aziz, for a very elaborative talk. So we will be moving on to the, before that, Dr. Hervé wanted to speak to all. Can we have...
Yes, can you hear me?
Yes, sir, we can hear you. Yeah.
No, just wanted to mention something about the talk of Jamalul. It's of course more challenging to face benign central airway obstruction because patients are not supposed to die from benign things. And so we, in malignancy, well, we know most of the time the result at the end, it's death. But in benign, Dr. Dumont, maybe, or other guys used to say that you marry the patients because you follow them for years and years. If you don't find the ideal solution. But the only thing I wanted to say is that I'm sorry because I have to go. I promised to my wife that I'll pick up one of my daughter to school, and so it was very nice to be with you, to see my old friends Patabi, Jamalul, Rajiv, Ravi, and all the guys. So thank you very much, and I hope again to see you in 2022. Okay?
Thank you, Dr. Hervé.
Bye.
Nice.
Bye. Bye.
Thank you, Dr. Hervé.
Hervé. Bye-bye.
Bye, Rajiv.
Bye.
Bye.
Au revoir.
So we are moving to the next session, which is an interesting case-based discussion. So the session will be moderated by Dr. Ravindra Mehta. So we have in the expert panel, Dr. Jamalul Aziz, Dr. V.R. Pattabhiraman from Coimbatore, Dr. Rajiv Goyal from Delhi, and Dr. Prashant Charjat from Bombay. So we have a series of 5 cases. The first case will be on malignant airway obstruction, which will be presented by Dr. Hari Kishan from a consultant interventional pulmonology at Yashoda, Secunderabad. Dr. Ravindra Mehta, you can go ahead with the webmeet.
Yeah. So good evening, everybody. Again, Prashant, hi. I think we just saw you coming in a while ago. We're going to miss Hervé, but I think it's still going to be interesting with all of your experienced guys. So I think let's start. The format outlined is the following, that in a span of around 7 to 8 minutes, the case will get presented by the speaker, and then we will direct questions towards the panel so as to have both an analysis of the case, what was done by the operator, what could have been done differently, some learning points, and so on. So do forgive me as I start catching and not picking on each one of you, so as to get some good learning points over here. With this introduction, we'll start. Hari, with your smile and your COVID, non-COVID gear, we will listen to the first presentation from you.
Greetings from Yashoda Hospital, Secunderabad. Dr. Raji Goyal, Dr. Pattabhiraman, Dr. Prashant Jacek, Dr. Ravindra Mehta, Dr. Balraju, Dr. Tinku, and my colleagues. I hope I'm audible, right?
Yes, very much.
You're audible.
So my case is on a bilateral mainstem obstruction, the case discussion on malignant central airway obstruction. So the title of this case, I have kept it as No Road Leads to Rome. She's a 54-year-old female, history of CA cervix squamous cell CA with metastasis. She received chemo and radiation therapy, currently on palliative chemo. Presentation was progressive shortness of breath to the oncologist. She had stridor at rest, and when she was lying down, her saturations were going below 50. And then they did a bronchoscopy and found there is a mainstem obstruction, and then referred to our center. She has come around 350 kilometers from my hospital. The request was for a therapeutic bronchoscopy under an ECMO support. So I have a CT image here. You can see both the airways are patent, but at the carinal level, you can see the obstruction there. So we did a rigid bronchoscopic assessment. So once we go in there, you see both the stems of the right main and left main bronchus are completely occluded with the tumor. So you see in the down video. So there is no path how this patient is breathing. Then the anesthetist said, like, there is no road to go, then you have to stop the procedure because he finds it difficult. This case happened when I was doing a tracheal TB stenosis repair. This patient had a code blue call in the department, and then we had to rush her inside the OT. I used an electrosurgical snare, electrocautery device, and then I was able to open, after 3 hours, I was slowly able to open the left main bronchus. And then I deployed a 12 into 30 bonus stent in the left main bronchus. As you can see, I am deploying the stent there. And then I was able to pass beyond the obstruction. The stent got expanded well after 10-15 minutes. And then I had placed it just above the carinal level. So I did a check bronchoscopy after 3 days. And the local, you see a well deployed stent in the left main bronchus. I was able to pass my 4mm scope beyond the stenosis. In the left main stem, I was able to open it. So then I referred back to the treating oncologist. She went back walking. Roommate saturation was 98% on roommate. And then she received 2 cycles of cytotoxic chemotherapy, comes for a surveillance bronchoscopy after 3 months. You can see I did not operate on the right main stem, but the right main stem is completely opened up after the chemotherapy sessions. And then the left main started to have stent-related complications, though the airway patency was maintained. There's a small mucosal tag related to the stent-related complication. So this is my case, and then she had lived almost for 6 months after the procedure, and then she expired. So coming to this case, what were the important points here is like, I could have done both the limbs, but it took almost 3 to 4 hours for me to open up the left main bronchus. So should I have done both the limbs at the same time? That is one question, because I had a code root call and no emergency things. Means the decision was taken on table. Current questions are like, should I exchange the straight stent to the wide stent now, or continue the oncology treatment considering the extensive spread? Thank you.
Okay, so that's an unusual situation, and Hari, the case is nice. It's very interesting. The only thing we didn't like is all roads lead to Rome. We don't like the mention of Rome. Let's keep it out there, and let's say all roads lead to Hyderabad. On a serious note, now let's start discussion of the case. I thought we could talk of 2-3 case points in every case. One is the challenges faced in the case. Secondly, what else could you have done? Hari has raised that question, and the third is some learning points. So let us start with our Malaysian guest and my good friend Jamal. What are your challenges which you perceive in this case, and how has Hari handled them?
Thanks, Ravin. I mean, I thought Harry did an extremely good job, actually. You know, I mean, to me, my first impression was that the tumor was, the malignancy was really extensive, actually. You know, so, and the patient expired up within 6 months. Did she? Yeah. So I'm not quite sure, you know, what else could have been done, or whether things could have been done better, considering that it was a very advanced malignancy. I thought, you know, you did well there, you know. So I have no further comment, Ravin. I've talked long enough, more than 30 minutes. So maybe I would like to hear from expert from India.
Yeah. So Prashant, Hari mentioned the fact that this case was transferred to him for ECMO, but he seems to have done the whole case without ECMO. And he mentioned the inordinately large amount of time it took because of the complexity. Your comments and thoughts on that?
Well, I think you know, Hari did a brilliant a brilliant job. I think what we need to learn from this case is that whatever you do is, you know, is what you decide at that point. You know, what is appropriate. And I think, you know, one would say, okay, both those main stem bronchi are blocked. Let's remove, let's debulk both of them. Let's put in a wide stent plus an additional stent down there if required to support it. All those things could have been done. You know, theoretically sound good. But I think if already 3 to 4 hours of anesthesia is done, one limb is opened, and I think at that point, the decision was, I think we need to respect that decision, which was taken at that point to say, okay, this is enough, because all of us need, you know, an intervention. You know, you can't keep on going. You know, at some point you have to say, okay, this is as good as it gets now and today. And I think you take a practical decision there. So I think, Hari, you did a brilliant job there. You said, okay, I've opened up one main stem bronchus. I think I put in a stent there, and you know, patient obviously you thought was being ventilated well, and I think I personally think it was a good job. Suppose you would have done it. I mean, you know, suppose you would have done this very easily in the next half an hour. I'm sure you would have gone in and done the second, limb as well. So I think everything really depends on how the case is evolving, and you know how things are evolving as you do the case.
ECMO, Prashant, the question on ECMO, since he was transferred, Hari did this whole thing on with ventilation. What about the application of ECMO?
I think, again, you know, I mean, I think I've not used ECMO so much as far as such interventions and debulking are concerned. But I think the point for I think, again, that's a very clinical decision. You know, if you think you could, you know, this having both the bronchi obstructed, and you could still, your anesthetist, I think this is where the good anesthetist team comes to the rescue. You know, you need to have a good dedicated anesthetist team who says, okay, I can ventilate this patient, you know, and you would say, okay, and let the pulmonologist do the job. If the patient was not being ventilated adequately, or there were problems, I think you would have needed to, shift to a better way of maintaining the hemodynamics and do the procedure. So I think that's my take on it. I think Hari did very well to avoid the ECMO. And of course, this would not have been possible without excellent anesthetic support.
Pattabi, let's talk of something which is very core. There is a learning curve for everything. Hari has shown a case where he's already in the midst of doing some difficult situation. And on top of that, this comes into the picture. You have a look at it. Now you go with the retrospectoscope. She has lived so much and so forth and so on. Your learning curve, your experience, amount of time it's going to take. And in India, you have to throw in a component of how are you going to face this family, the discussions. And if you were in COVID times, you'll be doing a COVID, wondering about the COVID status. And the fact is, what are going to be your outcomes in the long term and the economics of it all? Tell us what it takes to do such a thing. Would you say that a novice person should do it? Who should be the one taking it up? And how do you factor all these decision-making points?
Okay. First up, congratulations, Hari. That was a wonderful job done. But let's look at it this way. Now, this is a patient who's had malignancy, who's had a chemotherapy, who's got a radiotherapy, who's been coded now. Now, when a patient with a code with that kind of a CT, probably I've not looked at the CT, and with this kind of a thing, our initial impulse would be do not do anything. Just leave her go, because this patient has had your thing. Now, there are different situations where you have to get in. That need not necessarily be medical. There can be social reasons and so on. But upfront, if someone is a beginner, I wouldn't really want any beginner to go anywhere near this case at this particular point. Hari is a seasoned interventionalist and he went ahead. But I don't think this is for everyone to start off. I think this is something, because, ultimately, once you put the scope inside, then you'll have to do something, because you can't get out of that place. With that kind of thing, with an anesthesia, even a small orifice that the patient has been living, once the anesthesia and the relaxants go in, the patient is going to choke and you're not going to come back again. And this is going to be a procedure after which the patient is not going to wake up. So I think the first step is this has to be only in a tertiary and only in a very skillful area. And even that, I would really be very, 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 wary about, dropping my scope in such a situation. You look at a very, very small amount of area to work with. So that is, as far as Ravi's thing goes, whether will you do it, I will be very hesitant to even start it with this kind when the patient is code. If the patient is having a code blue and you go in, that's going to be, the outcome is not going to be that good at that point. So that's very, very, a frightening thing. But a good job done, I think, with all these things that we see. We as interventionalists, we love to see this. A patient was almost dying, has the 6 months of good lease of life. Second thing, if I may continue, is about whether you'll do only the stent or not. I think Prashant has clearly answered. Lesser the better, especially the patient has had a radiotherapy on. The patient who has had a radiation of very, very poor mucosa, and we can literally tear them. It almost sometimes go like paper, and you try doing something and you'll end up, having a mucosa which cannot be repaired. And we've also had certain cases where you put a stent and it just tears and the distal end opens and so on. So we'll have to be very wary about the fact that, we're working on a radiotherapy thing. So do less. And that's what I think he's done. Just the thing you have to do. This is a firefighting and you fought it and you just come out and it's very good. And the follow bronchoscopy you showed, it's a beautiful opening of both the things. In fact, I would have even tried to remove that stent in the left side, because at that point was quite okay, and there are stent related complications, but that can be discussed. So these are the things that come to my thing at this point. Anything, Ravi, I think I'll need your opinion as well. Yeah.
Oh, I'm not supposed to talk. Wish
Okay. Ravi, can I say something?
Okay, so I think what you made is a point which Arve talked about in his lecture, that basically there is an endoscopic outcome and there is a ultimate outcome to the patient, which is a functional outcome. And we saw the discrepancy he showed, which is widely demonstrated, illustrated in this case. However, this patient had a combined good outcome. So Rajiv, let me ask you the final question on this. That, Hari has taken this up, one case going on, second case he takes up of the highest order possible, indicative of his fiery spirit and of course his supple and wide open coronaries like the stent he put in. My question to you, you're the master of doing why stents flexibly, which I've heard a lot from you. How would you have handled this anyway differently? Is there anything else for us to learn if we are not capable of putting, rigid scopes and doing all these things? Will we let the patient go, or should we use?
Am I audible?
Yeah.
So I think in this kind of a situation, doing just with a flexible, trying to put a Y stent with a flexible is out of the question. So because you need to have an airway. However, I would like to comment that, under the circumstances when you have both sides blocked, almost completely blocked, like in this patient, I may have tried to, open with I normally use a cautery. Dr. Jamal, we don't use laser so much in India. So I may have used a cautery to initially open both sides and get some airway. And the only problem with the Y stent in this particular situation is that the carina is very, very broad. So you may end up, not being able to place the Y stent optimally because the carina is so broad, it would splay the Y stent, much wider than the angle which it permits. So I would first like to, reduce the carina on both sides by doing some cautery. And then if I felt that stent is required, because sometimes when you, open the carina from both sides, you may actually, not really require a stent. Because if you are able to, cauterize it and bring it down on both sides, you may end up in a situation where you're getting good airway. You may not actually require a stent. So I think it's a question of what you decide at that particular time. It would also depend on the amount of bleeding that you encounter when you're trying to do the cautery, and trying to see how friable the tissue is. So all those factors would count. But the first thought when I looked at Hari's case was that yes, possibly think about a Y stent, but first, open both sides with cautery and try to open the airway on both sides. First, once you have the airway open and you're able to put a thin scope and see, how distally you can go and what is the patency of the distal lung, then decide about whether you want to go for a Y stent or a single stent, which was very successfully done in this case.
Excellent. So
Ravi, one comment. It's interesting to see. Yeah, it's interesting to see. That after 2 cytotoxic chemotherapies, the left side, the right side also opened up. So I think that's what it is. This patient probably had received chemotherapy, radiotherapy, everything was resistant, and despite that, you see after on a follow-up bronch, the right side has opened up. So I think there's no right decision, no wrong decision. I think what you do at that point you feel appropriate is absolutely fine. I think.
Yeah, absolutely. And I mean, if you look at it retrospectively again, of course, if you had just opened the airway on both sides, maybe to about 40-50%, just with some kind of hot therapy, you may not require the stent at all, because you might find that after 2 months of chemo, the tumor has completely regressed. So it's sometimes, these things are not very predictable, and it's very difficult to judge, in a patient with a failure of chemo and radiation, how the patient is going to behave subsequently. So it's a question of what decision you take and what are the stents that you have at your disposal. Sometimes you may not have the right size stent in your inventory at that point of time, which you want to use straight away. So it's many factors are there, and like Patabi said, you do it only when you have some kind of skill and assistance of that kind to attempt that. So under the circumstances, I think the patient did very well, and Hari did very well to take the patient through and give her 6 months more of life, which is really very commendable.
And if I can add about the ECMO part, I think ECMO and the therapeutic, especially hot thing, coring and thing with all that heparin going on, it's going to be a huge challenge. ECMO in this situation with that kind of a 3-hour procedure with a lot of electrocautery coring and thing, and it starts bleeding, and you do not know what to do because the patient will having stiff dose of heparin going. I mean, it's difficult actually.
Absolutely.
Okay, so I think to put some closure points into this, a very, very interesting case Hari has brought out, which is the pinnacle of intervention, and that too coming at a situation in the worst possible situation. So there is a tough case, and there's a tough case which comes at the right end part of the clinical spectrum. So this one comes at the worst situation that a case can be. The interesting part is that paradoxically in the past, this used to be don't do anything about these guys, but that paper from Ost and all showed that basically the people in the worst functional status probably have the maximum benefit. It is a paradox which is portrayed very nicely in this particular case. Whether to do or not to do addressed, of course, that is the one issue which we've talked about. What is to be done? Again, talked about use of ECMO plus minus. But Patabi, to add to, there's a lot of people using regional anticoagulation, supposed to facilitate even hot therapy. then of course, whether it's only debulking and leaving it alone, debulking and stenting, obviously when patients come crashing, then the idea of putting a more permanent strategy is makes a lot of sense. And then of course the good response to later therapy, which clearly increases the longevity of this patient beyond any possible statistic at that point. So I think these are the take-home points and the learning points. Hari, again, we commend you, and it's an excellent case. With this, we move on to the next case. We introduce Dr. Nagarjun. Do I do that, Vish, or do you do that?
Sir, yes, sir, yeah.
So Vish has been forbidden to introduce Nagarjun, too much in the same system. Nagarjun basically is again a young star. Nagarjun, I'm calling you young, so it's a compliment to you. A young star on the intervention horizon, a part of the Hyderabad strong forte which has developed, and part of the Yashoda system, where he left his comfort in PGI and went on to the private intervention world in Hyderabad. And he has indeed not only made inroads, but put his stamp firmly on the scene along with his colleagues. Nagarjun takes on the next case.
Thank you, sir. I think we had excellent talks today by Dr. Harvi Dattao and Dr. Jamalul, and also one interesting and challenging case by Hari. So my talk was on benign tracheal stenosis. I hope I'm audible, sir.
Yeah.
Just trying to share my screen. So I'll be presenting a case of a benign complete tracheal stenosis. Just a couple of slides. We have a lot of causes for tracheal stenosis, but in our setup, the common causes which we see, I think the first thing, if you want to talk about tracheal stenosis, the most common cause we see is the PITS. That is a post-intubation followed by post-tracheostomy trauma, and then comes the TB. TB more often causes bronchial and bronchotracheal stenosis. But if we talk about isolated tracheal stenosis, PITS is the commonest thing which we see in our part of the world. And the case I'll be showing is a complete tracheal stenosis. So how do you define a complete tracheal stenosis? We have this classification here, grade 4, where we have no detectable lumen, is a complete tracheal stenosis. So this is just one of the things which we look at when we try to decide what has to be done. As Dr. Jamalul has said, there are so many other things which we have to figure in when we have to decide the choice of therapy, including the site of stenosis, the length, the number, the comorbidities, and in India also the socioeconomic factors. So this case actually was a 30-year-old lady who actually consumed organophosphorus compound with a suicidal intent. Unluckily, she developed intermediate syndrome, for which she had to be on ventilator for almost 3 to 4 weeks. And as a part of this process, she was tracheostomized. She was finally weaned off ventilator, given physio, and she was sent home. But sadly, they tried decannulation multiple times but couldn't do. So that was when she had come to us. So when we had first seen her, she was the vitals were stable. The neurological function was recovering, though she needed still some support to stand and walk. But she was very depressed because she was not able to talk. So this is the X-ray neck, which is projected here. As you can see, the tracheostomy tube is there. And above the tracheostomy, we see a complete abrupt cutoff of the trachea. So this was the bronchoscopy view, where we can see that above, this is through the vocal cords, and you can see that there's a complete cutoff of trachea. You can't even see any pinhole opening of the trachea. The same thing, I'll just play a small video of it. So again, the same thing here, you can see the at around 2 to 3 centimeters from the vocal cords, what you can see is a complete abrupt cutoff of trachea with no pinhole opening. So at this point, we discussed with the patient what had to be done. We offered surgical resection as one of the treatment options, because if it is successful, then it will be a lifetime cure for the patient. But then this was refused by the family on 2 grounds. First was that she had already spent 1.5 months in the hospital and they didn't want any more surgeries to be done on the person, and also for financial reasons. Then we had 2 options, either to leave her on tracheostomy like that, or then to try a bronchoscopic approach, try to dilate and then see if we can proceed. So because she was already depressed with suicidal intentions and she was very upset that she was not able to talk, we tried to go through the bronchoscopic approach. So this was how we started. The first thing was to see whether we can, if at all, try to create a tract. So this was what we had done. First, this is electrocautery knife to give the incision at the central part, where you can see a small white zone. So this is, I think, one of the trickiest part when we have to try to open a complete cutoff, because we have to be careful not to create an artificial lumen. So we just made a small incision. We saw we were still not through. Then again tried to go in a bit deeper. Normally we get a giveaway once that stenosis is completely punctured. So there it is. So after this thing, we will like to see the tracheostomy through the opening here. So we were sure that we were in the correct path. Then the second thing, even though we were sure, the second thing normally what we do in such a case is to reconfirm. So a guide wire is being passed through the rigid bronchoscope. Had this been in the bronchus, we can also use a fluoro to see where we are, but because we had a tracheostomy, the easier way was to see the guide wire now, which is through the bronchoscope passed to the tracheostomy. So now we have a guide wire passed across the stenosis from the vocal cord into the distal part of the trachea. Now that we have created the path, the next thing is to dilate the trachea. So this is something which is commonly done. Serial CRE balloon dilatation starting from 6 mm. We can just go on. This is just a video of the balloon dilatation being done, and once the balloon is adequately dilated, then you pass the rigid bronchoscope across the stenotic segment into the distal trachea. Once this is done, we can be rest assured that we have created a significant lumen. The last thing is to deploy a stent. In this particular patient, we decided to deploy the stent in the first instant itself. So this is a silicone stent which was deployed. It is being positioned. And once it is properly placed, you have to open the stent with either a balloon or using the forceps to open it out. So this is a stent now which is deployed across the stenotic segment. Now this I think will be the first part of the story, because the second part is follow-up. So once we place a silicone stent for benign tracheal stenosis, it is a long story which will just begin. So this is a follow-up bronchoscopy which was done around 4 months after the stent was placed. Lucky we were in this case because there was no stent migration and no much granulation in this case. So this is just one case example of a patient who had a complete tracheal stenosis where surgery was refused by the family, and we had to do a bronchoscopic approach and placed a tracheal benign silicone stent. So this is the pre-X-ray where X-ray is showing a complete cutoff, and this is the X-ray following the stent placement where we can see the lumen nicely in the lateral view. So similar experience, we have around 4 to 5 cases in the last 2 years. Most of them prolonged ventilator, post-tracheostomy, upper third of the trachea which is involved. Surgical option is given to all of these patients. 2 of them refused and bronchoscopic dilatation was done. One patient underwent surgical resection, but he had a restenosis and we had to place a Montgomery T tube. The 4th person is due for surgical repair post-COVID season. So this is again some images of the first one was the case which I had shown. Second is another girl with TB meningitis where she had a complete cutoff. Again, we had to place do a bronchoscopic dilation, place a stent. The third is the guy who underwent surgical repair, had a restenosis, and again we had to place a Montgomery T tube. So these are some cases of extreme benign tracheal stenosis where you don't see a lumen at all. But the more common variety is the one where you have some lumen to go inside, where our job becomes much easier. So to sum up, surgery definitely remains the cornerstone of management. But then in our setup, I think bronchoscopic approach also has some role, especially when it recurs after surgery, or the surgery is either unacceptable to the patient or surgery is technically not feasible. I think with this, I will end my case.
Okay, very interesting. So let's start with the usual questions. First of all, very interesting and again out of the box case Nagarjun, which brings up some interesting points to discuss. We start with the first 2 usual questions, the challenges and alternative techniques, which is non-surgery here. This time we start with Patabi.
Sir, please unmute them.
Yeah, lovely job, Nagarjun. This, I mean, all the cases that you showed was picture perfect actually. And yeah, we used to get these kind of cases time to time. The thing is, if it's too close to vocal cord, I think that's where you have the challenge. The advantage is when the patient is on a tracheostomy, you can take your time, do a proper thing, because the ventilation goes from somewhere else, so you can actually do a job properly. Usually you have a pucker, and from there, that would be a giveaway, so that you can concentrate on that and then start dilating, so that you don't really injure or go for a form of false tract and all that. So all this has been, the principles have been very clearly shown. What are the alternate ways are, I mean, since it's too close, I mean, the easier way, since there is already a tracheostomy, is one thing is to dilate it and put in a Montgomery. So that will be a safer option for a few reasons. One is, if you do all this in one go, and if you're not too sure about the vocal cords and how it is, because the patients are on tracheostomy for quite a while, and suddenly they'll have to start, this is decannulation happening all at once with the stent inside. And if there is a problem, you might have to intubate and all that. For that, a stent inside might be an issue. So those are theoretical issues, and hence to see whether it's okay, Montgomery is usually a very good idea, because you always have a T and a thing inside. And third thing is what Ravi has actually described, and it's a very fascinating thing. You have a dilatation, you put in a stent on the top of a tracheostomy and have a Shailis on a tracheostomy with a stent, which actually is a Desi Montgomery, which has all these things put together. So all these three things are actually possible if the patient doesn't want a surgery. And this will be a useful bridge for a surgery also, if the patient wants a surgery eventually. Having some tracks for some time, and then see if the patient doesn't get well after removal, can always subject the patient to surgery. I'm not too sure if I missed a lot, but anyway, a lot of great people around to fill up what I.
Yeah, so interesting, but I think you've added very nicely to the discussion. Jamal, your thoughts on this? Jamal, unmute yourself, please.
Unmute yourself now.
Right. Okay. There was an extreme case of tracheostenosis. Honestly, I've never, done such a case before, actually, So that was a great job, actually, And, so it just shows that bronchoscopic approach is an acceptable method to manage post-intubation tracheostenosis, actually, So although it's always stated that surgery remains standard, but there are very few centers in the world that have experience in tracheal resection. So I think bronchoscopic approach will remain, because there are always people who are not suitable for surgery. And I think that was a fantastic case, actually. And I'm not sure whether I was brave, confident enough to go through that, that wall, with hardly any opening at all, So I just want to know, were you guided by anything at all, when you puncture that piece of membrane, to make sure that you didn't create a false lumen, actually, So were you guided by anything, any imaging or anything at all?
I think Dr. Patabi has said, normally you see a small pucker. The central part of the trachea usually is little more wider than the remaining part. So I think that is a place where we start making the puncture. Or if the trachea is concentric, circular, then you choose the central part to make a first incision. I think that is how we do. There's no other way, I think, which we can help us. I think second thing is to have an idea of the length of the stenosis before we start doing it. If it is too long, I think it becomes a bit riskier. So all the three cases where we had done were around 1 to 1.5 centimeters only. So it was not a very long stenosis also.
You never had any complications in any of these cases?
So to be very frank, I think in the last 3 years, we had 5 cases of complete cutoffs. In 3, we could successfully create a tract. In 1, I think it was more than 2 centimeters. So we couldn't actually create a tract. So it was it. And the 5th case, we sent for surgery. We're just hoping that the surgery is done properly.
Yeah, so I think Ravi, if I can make a quick comment.
Absolutely, Prashant. I was waiting for you to get off the phone. Huh?
So I think I think that's a very interesting case, and I think all of us come across these cases from time to time. I think, like Pata mentioned, that you can have the puckering, and that's the point of entry. I wanted to respond to Jamal saying that you really need to have a very good CT scan to know what is the exact length of the stenosis that you're working on. Now, the only one thing is that Nagarjuna used the knife to make the hole bigger and bigger. What I would typically do is I just want to have a hole enough so that a guide wire can go and balloon catheter can go. That's all. So I limit the use of cautery and the balloon and the knife as much as possible. But again, I say there's no right thing, there's no wrong thing. It's you're guided by the situation then. But the principle would be, as soon as your guide wire is going in and you think a balloon catheter can go up, you can do it. And typically you can also use the if you have the fluoroscopy and the dye in the balloon, just to see how the balloon is opening up, what pattern it is the balloon all across the stenosis or not. So I think these are some of the additional points which one can use. But again, you are always guided by what is the most appropriate thing on the site when you're doing the case.
Lovely. Rajiv, the voice of experience.
Yeah, so I think that the tracheal part, the tracheal complete stenosis is sort of more amenable. But if you get into a situation where you have a main bronchus stenosis like this, especially we've seen quite a few cases of left main complete stenosis. That is where the chances of creating a false passage or injuring a nearby vessel becomes much more. And although Nagarjun did mention using a fluoroscopy, but many times the collapsed lung around it, it doesn't allow you a very good image. So we recently had a patient of Wegener's granulomatosis, giving rise to complete obliteration of the left main bronchus. And although we used imaging and everything, and we tried in a similar fashion to create a passage, but we were unable. So it's a question of how much your imaging can guide you in terms of the length of the obliteration that is there. And I imagine that in that patient with Wegener's, the whole of the left main bronchus had kind of completely become adherent, and because of loss of cartilage, had become completely sort of fused. So we were not able to create a passage. Any experiences, Dr. Jamal? Any experience about? You mentioned these young females, with coming with complete obstruction. So we have seen several of these young girls, 18 to 23 years of age, coming with complete obliteration of the left main bronchus. And have you been able to, kind of dilate any of those patients? I mean, sometimes you put a pinhole, it becomes easier. But if there is complete obliteration, we have not really been able to be very successful in those patients.
I mean, frankly speaking, I've seen only 1 or 2 cases of post-TB stenosis where there was a complete obliteration of the lumen, and I have never attempted, any dilatation.
Yeah, because they want to get an autoimmunity kind of.
Actually, we're taking a risk. Actually, we try to, puncture that's thin membrane actually, unless we are absolutely sure actually. So I've never done myself actually.
Yeah,
and Ravi, you are the moderator, but you might pull in. Say something about this.
Okay, so some closure points on this. Thank you for the comments. In the interest of time, I'll make some closure comments. Nagarjun, first lovely case to bring up.
Ravi, can I interrupt for a second before we close it? I think I'll keep it short. I think the important thing here is that all of these main bronchitis are very challenging, and they're benign. Often the lung dystally are often non-functional. So I think that also adds a very important. You need really a good reason to attempt the bronchial stenosis opening in a benign condition. You don't know how long it has been closed for. And I think I agree with Rajiv and others. It's extremely difficult to open up the bronchi compared to the trachea, because you know that after opening the trachea, you can ventilate and you can achieve something. But if the distal lung is completely gone and for a long time, then I think it might not be worth the risk.
Okay, so lovely points by the panelists after this provocative case. So Nagarjun, thank you for bringing up this case. But since we have to always talk of some learning points and point counterpoint, which is the whole theme of the experience today, few things out there. One, the patient was, you said, didn't want surgery. But understand that you take this up, the chance of false tract is there. So you're potentially looking at another surgery if something happens. So that's something which you do. And this is the classical phenomena of winging or walking the tightrope and intervention. Be as it may, your success speaks for itself. Secondly, we have also found that sometimes when Patabi mentioned what conduit will you use? So you have recanalization, you have conduit. Recanalization has all the challenges has been talked about. The conduit can either be as the stent you put in, which is like a large stent. And I was wondering whether a little smaller could have been okay, but it's a choice you make at the bedside. The second is a T-tube, which is a safety paradigm. And third is what we have described, that you take the tracheostomy and put a small stent on the top, and that was published as an innovation in laryngoscope. The issue to do some of these things is because the T-tube and or the other innovation will actually give you more insurance. Because if the stent again granulates above and below a 6 centimeter stent, again you're looking at more procedures. Secondly, the healing of the tracheostomy after a stent has been an issue we've had to deal with sometimes. Long-standing tracheostomies, you put a stent and that large hole to heal, but because it actually granulates on the base and the base has actually got a foreign body there, is a challenge you have to face, but something to think about when you look at all these things. And the final point is that ultimately these are out of the box things. The access is the main thing you guys talked about. So trachea, larger lumen, puckering eventually is a very good point. If you don't have puckering, again, you're winging it or walking the tightrope, and that is the main challenge. You use the cautery knife, you also use the ball tip, and very gingerly you go through, praying as you're doing that. And at the same time, you quickly try to see that you're constantly in the lumen. So again, a challenge, so novices should not attempt it unless a high degree of confidence is there. In terms of bronchial closure, as Rajiv talked about, very, very difficult, because usually if they're eccentrically closed because of a vasculitic process or tuberculosis, that is winging of the highest order. All your conduits are angling. So unlike the tracheal opening, it's very difficult to open. And confessionally, the first one we tried many years ago wound up becoming a dehiscence. And that was the genesis of innovation number 2, when we had to block it up with the blocker we have described and to save that bronchus over there. So again, in the airways, it's challenging. What has been done in literature is that the end-stent people, the Korean guys have described TB bronchostenosis of a complete nature, where they've opened it in the bronchus, but it's extremely difficult to replicate and quite challenging to take on. So these are most of the points around this interesting case which Nagarjun has described. Thank you so much, Nagarjun.
Most welcome, sir.
Okay, I think with that, we go to the next case now. And I think we're moving a little slow for time, so I may wind up decreasing the questions on the next one. So the next speaker we have is another Hyderabad. One second, let me just see. It's okay, Balaraju. Okay, so Balaraju again from Andhra. Balaraju again has been in the scene, a quiet but accomplished person who has taken intervention to the hinterlands of the south and given it a new shape over there. And he's going to describe a very challenging case, which he has shared with us also. Balaju, we look forward to looking at your case.
Thank you, sir. So first of all, a wonderful job, Vishwesh, to pull on good international faculty and the eminent national faculty. Respects to all. So I'm going to present a foreign body of at the subglottis. So this is a story of a 4-year-old girl presented with a history of aspiration of a whistle, followed by a stridor. So she presented to the ER at around midnight, 1 o'clock. So 8 hours after the presentation, the baby was conscious. She was having a stridor with whistling sound at rest. So this is the, I hope it is audible.
Very much.
So 8 hours after the aspiration, the baby was completely conscious, normal, no breathlessness, only a stridor with whistling sound at rest. But what happens, just in 30 minutes of time, she has a rapid deterioration. During the counseling part, to explaining the patients what has happened, in 30 minutes of time, there was rapid deterioration. In such a way, so when she was on room air, it was 98, and suddenly the saturation was 80% on 15 liters of oxygen with severe tachypnea. And she went into altered sensorium with a PCO2 of 60. Yes, she had more stridor, so anesthetist was there in the ER. So we are explaining the family what has to be done because there's a case of a subglottic foreign body. So this was an X-ray which was done when the baby was absolutely normal. So in the lateral X-ray, you can see the vessel at the subglottis. See, what we have done was, because the baby was crashing, so we have to take the baby with an emergency to a rigid bronchoscopy under general anesthesia with jet ventilation. So there were many challenges because it was a crash situation. The baby we are losing the airway. So what we have to do is to maintain the patency of the airway to control the ventilation. So remember, it is a subglottic foreign body and it is completely obstructing the ventilation. The first thing what was done was to push the foreign body deep inside the trachea, not to try to remove it. So basically it was done because to maintain the airway patency and to control the ventilation. So once we have controlled the ventilation, now we have tried to remove the foreign body in the subglottis. As you can see, the optical forceps, we are trying to hold the vessel. So initially we hold the whole part, and later we try to hold the one edge of the vessel and try to remove it. So we have done multiple attempts try to removing the vessel through the subglottis, but most of the attempts have been failed. The reason being, so at the time, during extraction through the subglottis, there was a tight edema. So we did a multiple attempts. You can see so much of puckering of the vessel, which was absolutely normal before. So invariably, we could not remove the vessel through the subglottis. So the reason was the severe edema of the subglottis. So after multiple attempts, what happened was the disaster. So the optical forceps jaw has broken inside the airway. So you can see, so that's the optical forceps. Now the right optical forceps jaw has been broken inside, because obviously I was trying to compress the foreign body and to try to secure the foreign body inside the rigid bronchoscope to try to remove it in toto. But unluckily, the right jaw of the rigid optical forceps has been broken. So now you have another foreign body inside the airway. So that's the jaw of the right optical forceps. So luckily, I had a second standby optical forceps. I used another optical forceps to remove the broken jaw initially. So that's the broken jaw, you can see. So we have removed the broken jaw with no problem because it's very small. So now after multiple attempts, the problem is you are not able to retrieve the foreign body through the subglottis. So we have tried, as I've told you, we have tried many attempts to do a screwing movement at the subglottis and try to extract the foreign body inside the rigid bronchoscope, but it failed. So what else can be done? So what are the other options we have? Yes, we can use a balloon to extract through the subglottis, but unfortunately it is not so easy because the power required to extract over the subglottis is much superior for a rigid forceps than compared to the balloon or a basket. Probably basket also would have failed. I have not used balloon and basket, but that was the logical explanation I had in my mind. So now why is the reason you are not able to remove the foreign body through the subglottis? The reason was the subglottic edema. So this was basically because of impacted vessel inside the subglottis, and also because of multiple attempts through the rigid bronchoscope. So what next? What can be done? So obviously the first option is to do a tracheostomy or to leave the child there. So during the procedure, we have called the ENT for backup, and because it was late, very midnight, it was almost around 2:30 in early hours. So we could not get an ENT backup. So this is what we have decided. So yes, the baby is not going to die because we kept the foreign body inside the right main bronchus. Obviously, we can ventilate the left main stem bronchus. The baby is not going to die now. So now the option of doing a tracheostomy or to do something else. So we have gone ahead to do dilatation of the subglottis with increasing bronchoscopic diameter. So in the pediatric, this is what I use, the Karlstor set. We have the 3.5 size, that's an outer diameter of 5.7. This is the bronchoscope I have used for this case, the 4-year-old child. So what we have done was to dilate with serial bronchoscope of increasing diameter. The next scope was size 4, that's outer diameter of 6.7. And the next scope size 5, outer diameter of 7.8. So we've dilated to 7.8 mm. That's where we thought it's easy for us to remove the foreign body. So obviously I don't know the diameter of the vessel. So this was the last attempt I had to try to remove it. So as you can see, initially I'm dilating with the second scope. That's the size 4 rigid bronchoscope. So you can see initially I'm at the subglottis. I'll just go forward. So I've dilated with the size 4. So you can see the foreign body in the right main bronchus. So after I dilated with size 4, so then I started dilating with the size 5 rigid bronchoscope. That's the outer diameter of around 7 mm. So I had initially a bit difficulty in dilating with size 5 because the edema was there. So once I could able to pass over the subglottis, it was very easy. So the next option was to, again, the same thing, catch all the foreign body with an optical forceps and try to remove it. This was the last choice I had. It was almost 1.5 hours at the procedure. So luckily this time, after dilatation of the subglottis, I could able to remove the foreign body. So that was the foreign body, a vessel. This is what it is. So these are the important points in this case. The first thing is impacted subglottic foreign bodies are very dangerous, even when the symptoms are subtle. So they can worsen in no time. So in cases of subglottic edema, when foreign body can't be extracted, serial dilatation of subglottis can be tried before tracheostomy. Yes, if the option of tracheostomy is there, probably we can do it. So always have a spare instrument in hand. So luckily I was lucky because I had a spare instrument in this case. Otherwise I wouldn't have done the case, and there was an extra foreign body inside the airway. Thanks a lot.
Okay, interesting. Lovely case, Bala. And I think it sets the stage for, I think we'll take 2 comments this time. We are fortunate with us to have Rajiv here. In case those of you who don't know, Rajiv, 2012 Journal of Bronchology, 226 cases, 1 decade-year experience, foreign bodies in children. Rajiv, I rest my case. The stage is all yours.
Yeah, so Ravi, very interesting case. I think the main thing is that if the foreign body is larger than the larger than the diameter of the scope, which is probably what it was with the least size of the scope that Bala used. That is where the problem was, and as soon as he was able to put in a scope which was slightly larger than the foreign body, and which you saw that in the end when he took it out, he could keep the scope there while bringing the edge of the foreign body into the scope. He was able to remove it quite successfully, and I think that is the key point here, because at the glottis, at the subglottis level, and even at the level of the cords, you find that these foreign bodies, because of the edema and because of the configuration of the foreign body, will tend to get stuck, because of the foreign body coming, being slightly larger than that place. And which is why, when he was trying to twist the foreign body, even by holding the edge, he couldn't take it out. So I think, Bala, the learning point which you have, discovered, and all of us have discovered it the hard way over a period of time, is that when you find that you've gone inside, you find a foreign body which is slightly larger than the scope that you're using, and you're finding that you're coming at the subglottic level and you are not being able to bring it out, is to probably just stop there and not try to, repeatedly try to pull it out, but to leave it inside and put in a larger scope, which will automatically kind of dilate that area, and then try to bring that foreign body within the scope, and then remove both of them together, which is probably what you did at the end. So I think it really brings out this very important point. And again, middle of the night, being able to do this with very little support speaks volumes for both your courage and your skills. And the other thing is that it also brings to light that you should have a complete set of instruments, because we have time and again found that the more number of accessories and instruments you have while doing these foreign body work, the better off you are, because you do not know in the next foreign body which particular accessory will come of use. So having the entire range, and most people who are doing foreign body work will over a period of time accumulate all these various accessories, which will come handy from time to time. Lovely case, very nice.
Very nice, Rajiv. I think you summarized most of the points in this case. Prashant has to leave. Prashant, can you give some final comments, and then we can you can go ahead.
No. I think Rajiv has actually summed up in a very nice way. I think so. I have no additional comments for this case. Yeah. So thanks, guys. I think it's great to see all of you. It seems normal now. It seems good that we could all of us connect on such a platform. So yeah. Thanks a lot, everyone.
And good we are not talking about Corona and COVID.
Absolutely, Rajiv. I mean, this seems to be our normal. Okay.
I know.
For those of you who don't know, Prashant is the lead author on the IAB guideline on COVID bronchoscopy, which they're shortly releasing. So Prashant, you're as COVID as COVID gets.
Thanks a lot, guys. Take care, stay safe. Bye-bye.
Sure. Bye-bye.
Hi, Prashant.
Okay, Bala, one final question is that there's a zero-tip basket is there, which has got a very firm grip. So here the struggle is that whether there is edema, can a firm grip instrument manage to slide past the edema in a step prior to dilatation? Is that an option?
I have not tried in this case, sir, because I was using a rigid instrument here. But I had used a zero-tip basket that's from Boston, what you're saying. So yes, it is a nitinol basket. It doesn't have a tip. Obviously, the grip is good, but the problem is when you're extracting through a narrow orifice, most of the times the basket slips. It doesn't have very good force as compared to a rigid instrument. So that's what my take was. Yes, I am biased. I have not used the basket in this case. I've used it before and I also failed extracting through the stenotic area.
Sorry for interrupting, but I think basket is not the ideal way for this case. A basket would, you might actually end up with a broken basket also inside. So, in a situation like this, probably the way he managed it is probably the best way.
Excellent. So I think we thank you, Bala, for bringing up this interesting case among the trio of lovely cases we have done so far. We move on to the next case. Dr. Vishweshwaran, again, since you have started the entire meeting, you need no introduction, but you are the youngest IP person on the Yashoda landscape who has certainly made his mark over there. And this meeting also speaks volumes of a lovely intervention pulmonary forum. Vish, the next case is all yours.
Thank you, sir, for the introduction. So my case is, can you hear me, sir?
Very well.
So my case is one pill can kill. So this is the case which I had 2 days after I joined Yashoda. He was a 50-year-old male, non-smoker, non-alcoholic, with no comorbidities, presented with sudden onset persistent cough for 3 days, breathlessness for a day, swelling of the neck for a day, but there were no other symptoms. So on examination, we had a patient with a saturation of 92% on room air, pulse rate was 110, respiratory rate was 28 with use of accessory muscles, hemodynamically stable, but chest was suggestive of decreased breath intensity on the left side. And on the, as we can see from the picture, the neck was swollen and there was presence of palpable crepitations, and the patient had bilateral subconjunctival hemorrhage. So an X-ray was taken and that was suggestive of a decreased lung volume on the left side, but there was an evidence of a pneumomediastinum and subcutaneous emphysema as well. So for evaluation, patient CT scan was done. As we can go through the mediastinal cut, there was a collapse and there was a calcified radio-opaque material was seen. So this was the radio-opaque material which was seen obstructing the left main bronchus with an associated collapse. And in the other sections also we can see the calcified lesion exactly causing the cutoff of the left main bronchus. So a parenchymal window was also suggestive of a collapse, along with there was a presence of a subcutaneous emphysema as well as a pneumomediastinum. So on probing, then the patient recollected that the cough started following an intake of, even though we are not very sure, probably a ranitidine or a loperamide pill 3 days back, following which the patient had a recurrent bouts of cough that persisted, though the severity had decreased. So then since we suspected a pill aspiration, the patient underwent a rigid bronchoscopy. So this is a video that is showing the rigid bronchoscopic intubation. So we entered into the, we intubated the patient with a rigid bronchoscope, and followed by that we, through a flexible bronchoscope, we saw a presence of a white fluffy material almost occluding the entire lumen of the left main bronchus. So since the patient, since it was a, we assumed it to be a calcified thing because it was a radio opaque. So we instilled a saline over this to make it a cryosensitive, because metals are generally not cryosensitive. So following that, we tried to create a lumen in the center of this mask, because we didn't want to hold it with a rigid bronchoscopy forceps, which will cause the disintegration of this entire pill. So following that, we tried to make a hole through the center with a sequential cryo extraction, as we can see from this picture. And following that, we tried to remove this entire pill away from the mucosal wall, so that to prevent the injury of the mucosa by the application of the cryo. Then we tried to extract all the pieces piecemeal. And after that, what we could see was there was an entire very thick granulation, and the flecks were totally adherent to the mucosa, and the mucosa was very fragile. So then we knew that if we leave the pill like that, it is going to further cause granulation and stenosis. So we tried to remove it by teasing out each material with the blunt end of the Fogarty balloon. Like we tried, it almost took almost 2.5 hours to 3 hours. We tried to remove the entire flex from the wall of the mucosa without damaging the mucosa. And following that, the remnant pieces were extracted with the help of the flexible forceps through a flexible bronchoscope. And we used the gauze soaked in the saline to take out all the remnants that were sticking onto the mucosal wall. Following that, this was the image we had at the end of the procedure. We were definitely able to recanalize the lumen, but the lumen was totally edematous and with a lot of flex remaining, and there were we anticipated probably the patient can land up in a bronchial stenosis. So we started the patient on empirical steroids, as well as we gave him adequate bronchial dilators to maintain a bronchial hygiene. So the procedure was a recanalization of the airway with a rigid bronchoscopy with a cryo extraction, along with a mechanical dislodgement with the Fogarty balloon tip and forceps. And this was the X-ray which was there post-operatively, where we were able to get the resolution, where we were able to expand the left lung. And luckily, 2 weeks post procedure after steroids, there was a very significant relief in the edema, and all that we could see was a flecks of the pill that are remnant. But this time we didn't attempt to further remove this because there was an excellent recanalization and the patient was totally asymptomatic. So this is the post procedure 2 weeks later, where there is a complete resolution of the entire lung, and there is no evidence of any pneumomediastinum or subcutaneous emphysema. So just to sum up, it was a case of an inorganic foreign body for which a cryo was used. So to make it cryosensitive, we instilled a saline over it. And early bronchoscopic surveillance and intervention is especially indicated for this pill, because they have a tendency to cause excessive inflammation and granulation and can lead to sequelae like stenosis. And most of the dissolved pills may remain underdiagnosed. And the multimodality approach using cryo and even mechanical dislodgement helped in this case. Thank you.
Very impressive, Vishweshwaran. So unfortunately, in a e-platform, you cannot clap. If you could clap, do that over here for, of course, you and all the lovely cases presented before earlier also. Jamal, your thoughts on what he has done? And also, we would like to hear some comments on pill, swelling of pills, modalities, and your experience with pillology in the bronchus.
Right. I mean, I think 1 or 2 years ago, I had almost similar case. You know, a female patient aspirated a pill, and then we removed the pill, and a few months later, she developed right main bronchial stenosis, which we had to dilate. So I agree with Vishweshwaran that it is under-recognized, but I had a similar experience actually, and with regard to how he did the procedure, I think I couldn't have done it in a different way. I would have used cryo as well, to remove the pill actually, So what he did was great actually,
Excellent. So that's Jamal is trying to prototype the chill pill, Patavi. Tell us more about what you would have seen. Modalities used. This is a young interventional pulmonologist coming back in his first week in the country, and he has shown a remarkably challenging case. Give us some more learning points and some take-home points on this.
Yeah, so Phil, if you've listened to Dr. Atul Mehta speak about this, I mean, he's got a whole series on how pills are the most unrecognized things. The thing about the pills are the different things. One is the pH of the thing and the irritation. All the pills can cause a lot of irritation. So the mucosa is really bad, and you'll have to remove the last bit to get the airways back. And it's very challenging because you'll not know where the pill is, what the mucosal irritation is, and so on. Good job done, actually, Vishwesh. Yeah, you have to have multiple attempts. So rigid bronchoscopy is the ideal conduit for that. If you don't have rigid bronchoscopy, even a simple endotracheal tube is good enough. The thing is, in these cases, you'll have to go in and come back, go in and come back. So it's not a good idea to pass the vocal cords on and off. So the best thing is to take the patient in GA, take a conduit, preferably rigid. If you don't have a rigid, it's fine. You do a larger size of the endotracheal tube that goes in. And you'll have to do multiple things. It's usually piecemeal, and the ideal thing will be, as Vishwesh showed, a cryo thing. And that's the reason why you want a conduit to have a very safe procedure. And well, I'm not too sure if I'm missing anything. Ravi, you'll have to.
No, so excellent point. Ravi, in your 220 series, tell us more about the pills you saw and the pill lessons.
Yeah.
Rajiv, unmute, please.
Unmute.
Yeah, I was wondering whether some kind of a curved forceps, when you put the rigid there, and you've got that whole, kind of conglomerate pill there in front of you, would it have been also an option to put a curved forceps around it and just try to gently dislodge the whole thing en masse, and rather than trying to do it with the cryo and get it out piecemeal? Would anybody would have thought of trying that?
In fact, we put in cryo, hoping that it come as a en masse.
Yeah,
it may not necessarily happen.
That was not happening.
Yeah, that was not happening.
So I mean, one may have thought of that. I mean,
maybe like Prashant says, there's no right or wrong answers here.
When you have these very soft foreign bodies inside.
Okay.
For example, soft peas and stuff like that. Then these curved forceps, try just get them around that and try to bring it out. I mean, that is something one could have thought of.
Well, it can be epitomized.
The clearance was well done eventually. Yeah. But I think the Pata's point is very valid, that you need a conduit, because you may have to just go in repeatedly and in and out, and even though you may be doing whatever you are doing with the fiber optic, but because you have to go in repeatedly, even an endotracheal tube, even if you don't have a rigid, would make a lot of sense.
So I think the interesting point is what you mentioned about the en masse removal of the pill, is that the crumble leads to the jumble. And I think the fact is because it broke over there is where the whole problem came up. To summarize this interesting case with Vish brought up, is it basically prototypes one of the most difficult aspects of an organic foreign body, that too which goes and gets lodged in a challenging location, the left main bronchus here, where the curves are much more. That too distally already has sequelae. So you're dealing with a complex foreign body. You're dealing with something not only which does its obstructive function, it also has interactive function with the mucosa and a chemical function. So it leads to more problems. It itself disintegrates, so cannot be taken out en masse, which is another problem. It causes distal sequelae, which is also a problem because of infection and the hypoxemia and what you have to deal with in procedure. And the fact is that when you have to take it out, it's a long procedure also because of the crumbling nature. Not to mention the fact that there may be sequelae later of mucosal damage, stenosis maybe, and which has been also talked about, and infection also, the small particles which are distal, which may continue the cycle of irritation. So many interesting aspects come out in this case, and certainly the management and the way it was handled is a significantly interesting way of how it was managed, with some options mentioned. Clearly very well done, Vish. So I think we move on to the next and the final case. we introduced Dr. Tinku Joseph. Those of you who are presenting, you have to forgive me. I have not been leaning on you as panelists. We've been leaning on the others. But Tinku here is here to present the final case. Tinku is well known in the Indian intervention scene, and when it all started, it started somewhere. The intervention scene started somewhere in the middle of the country, and then it went south when Pattabi bought his EBUS, and then went more south when Amrita started to do it with Tinku being one of the leaders over there. The south scene has been made more prolific by Amrita, the work done over there, and of course their national meeting which they hold every year. So Tinku is going to regale us with one of his more complex cases, which will set the stage for some interesting discussion.
Thank you, sir. Hi, everyone. Is it possible to see my slides?
Yeah.
We are seeing your slides.
Sure. Okay. Very good evening, one and all. At the outset, let me thank Vishwesh and the entire Yashoda team for giving me an opportunity to speak a few words regarding benign airway obstruction. And in the next 5 to 10 minutes, I'll be discussing an interesting case of benign etiology which has caused central airway obstruction. Greetings from God's own country, Kerala, and our institution, Amrita Hospital, Kochi. So before discussing my case, there are different causes for central airway obstruction. We have already discussed a range of malignant conditions. There are certain benign conditions also which can predispose to central airway obstruction, like benign airway tumors, certain forms of lymphadenopathy, vascular pathologies, cartilage disorders, various granulomatous conditions, pseudotumors, hyperdynamic conditions like tracheomalacia or bronchomalacia, various congenital abnormalities, and as well as there are certain other conditions which can predispose to benign airway obstruction or a benign central airway obstruction. So moving on to my case, this is a quite familiar case for most of the panelists. This is regarding a 61-year-old male patient who is already a diagnosed case of severe COPD, who apparently presented to my clinic with complaints of cough, shortness of breath. He had significant orthopnea as well as stridor. And he was already a diagnosed case of tracheobronchial rhinosporoidiosis, who was apparently on treatment with Dapsone, and he was not getting significant response to Dapsone, and he was diagnosed almost like 3 to 4 years before, and he was on Dapsone. At that time, he was quite stable. He had progressive breathlessness, but there was no stridor. So when he visited my clinic, there was a stridor, and spirometry was done from another center which showed a significant drop in FEV1, and echo showed severe pulmonary hypertension. So this was his chest X-ray. Chest X-ray seems to be quite okay, apart from hyperinflated lung fields and low flat diaphragm and all those things. Apart from that, there is no significant pathology detected on chest X-ray. And this was a CT image. The CT image, as you can see, there are multiple polypoidal lesions involving the central airway. I proceeded with the bronchoscopy, and the bronchoscopy showed multiple the classical strawberry kind of lesions involving the central airway. I mean, this is the tracheal lumen, and this is the carina, and the lesion is almost occluding completely the left main bronchus. So there were multiple lesions which are extremely vascular lesions involving the central airway as well as the tracheal lumen as well as the left main bronchus. So these are the typical rhinosporoidiosis lesions, which are often difficult to treat condition, and there is no definitive medical management for this condition, and unfortunately, most of these patients will have to undergo different forms of surgical modality, like resection is the only option. So what next? I mean, this patient is a case of severe COPD. He is having severe pulmonary hypertension, bad FEV1, stridor. So initially, I inserted the rigid bronchoscope, and the rigid bronchoscope was placed in the subglottic area because the lesions were extending almost from the proximal part of trachea. But unfortunately, we found it quite difficult to ventilate this patient. For the reason is that there was significant amount of air leak through the rigid, and the anesthetist was not at all comfortable with doing a rigid bronchoscopy guided debulking of these lesions. So what next? So we had a discussion on table regarding what are the other options. We have to take out these lesions, otherwise, the patient will be in serious trouble. So rigid bronchoscopy was out of question. I had to remove the rigid barrel, and I had to offer something else. So there came in mind, the anesthetist told us an option of an extra long endotracheal tube, often called as a microlaryngeal tube, which has been often used by the head and neck surgeons or the ENT surgeons. So this is the extra long microlaryngeal tube, often called as the MLT or an MLS tube. And there is another variant of this tube, which is called as the laser protected MLS tube or an MLT tube, because it helps in, generally when we use electrosurgical equipments with a flexible ET tube or a MLS tube, there is always a chance for damage of this tube. So in such conditions, it would be ideal to use a laser protected endotracheal tube. It's difficult to obtain it. Most of our head and neck surgeons will be having it. So at that moment, I didn't get a laser resistant ET tube, the MLS tube. I had to proceed with a normal microlaryngeal tube. And this is the microlaryngeal tube, and this was the multiple lesions. You can see the lesions were approached with snare debulking, and the lesions was taken out with cryoprobe. So now let's see the video of the procedure. So this was the lesions again involving the central airway, and this was the post-procedure results obtained. So these are the lesions which are involving the central airway, especially the proximal part of the trachea. This videos, the initial part was taken after inserting the rigid bronchoscope. At that time, the MLS tube is not there. So this is the MLS tube or the microlaryngeal tube which I was talking about. The rigid bronchoscope has been taken outside, and the MLS tube has been inserted. And you can see the lesions behind the MLS tube. With the tube in place, I started working around the lesion, and the lesions were debulked with snare electrocautery. So when you use snare electrocautery with a flexible ET tube, you should be extremely careful, because there is always a potential chance for damage of the ET tube. So once the lesions were debulked with standard 2.4 mm flexible cryoprobe, the lesions were retrieved back. So once a major chunk has been taken out, I'm going down and to the carinal region. The next set of lesions was taken out, again with a similar approach of snare debulking, and followed by retracting the retrieval of the lesion with the help of a cryoprobe. You can see the extent of the bleed during this procedure, because generally rhinosporidiosis lesions are extremely vascular ones, and this was one of the concerns which the anesthesia team had, because already patient is a bad COPD with a poor lung function, and if during debulking, if it starts to bleed, we'll be inviting danger. So once a tube is there in situ, the advantage of having an MLS tube is that your airway is secured. You can walk around the tube, and once the cuff is inflated, the blood is not going to leak down into either the left or right lung. So see, the bulb is inflated, and I'm working around the tube so that the blood is not leaking down into the lung parenchyma. The airway is secured, and the procedure is much more safer one. So once the lesion has been debulked, I'm going into the left main bronchus. And once I reach the left main bronchus, I removed the MLS tube. The MLS tube was removed for the reason is that once the tube is there in situ, we get hardly any working space to use these electrosurgical equipments. So once I debulked the tracheal lesions, I removed the MLS tube, inserted back the rigid bronchoscope, and started working around the carinal lesion as well as the left main bronchus lesion. So this is the fiber optic bronchoscopy, which was done post debulking of the tracheal and the left main bronchus rhinosporidiosis lesion. And compared to the malignant ones, the benign ones gives us a satisfactory results. The mucosa looks like back to normal after debulking. And when we debulk such lesions, we almost get satisfactory results compared to debulking any malignant lesions. So the take-home points of this particular procedure is that this is something alternative compared to rigid bronchoscopy, that is using a microlaryngeal tube. And there are plus points as well as the minus points for this technique. The plus point is that it prevents aspiration of blood into your airway. It provides adequate ventilation throughout the procedure, as well as it increases the confidence level of the bronchoscopist as well as the anesthesia team. But the disadvantage of using this technique is it reduces the working space for the bronchoscopist in a considerable way. Also, when you have to manipulate the upper airway multiple times because there is no rigid conduit, and you have to pass your flexible bronchoscope as well as the electrosurgical equipments multiple times through the vocal cords. So there is a potential chance for damage of the upper airway as well as the cord when you manipulate through this area multiple times. So these are the notable disadvantages of using this technique. And the final point would be that tracheal rhinosporidiosis is an extremely difficult to treat condition. There is no medical management for this condition. And sadly, this is a recurrent condition, and most of these patients are chronic patients, and they will have to undergo repeated bronchoscopic techniques for removal of these lesions. Thank you so much.
Excellent. Thank you, Tinku, for a detailed, unusual, highly tropical, complex south-based condition. I think the one person whom I think is the ideal person to comment on this, who has also experience in both the disease and the intervention aspects, is Pattabi. Pattabi, your comments.
Oh, yes. Oh, wonderful job, Tinku. I mean, this is, we have a experience of 5 cases so far, and that would be, I mean, for this disease, it's quite significant. The few things here. The presentation of tracheobronchial rhinosporidiosis, it seems to have predilection to trachea and main bronchus proximal. There's not much distally, usually. And there are different ways. One is the multiple thing like what Tinku has, and that can be solitary. We had one solitary church bell like a thing which almost occluded a thing and was working like a ball valve also. And the usual thing will be a solitary, and usual thing will be multiple. And usually after a long time, it will develop, roots from different places. So there will be one big polyp. If you think that it's only one base, there can be 2 or 3 bases, and the root can actually get bigger. The more time that they stay there, the more the root gets bigger. It's eminently snareable, and that's what Tinku has shown. It's usually something that can be snared well, especially if it is early. Later, once the tube becomes a little big, you will have a little bit of an elevation, but still you can do a good job while doing a thing. As against it, nasal rhinosporidiosis, the tracheobronchial don't seem to bleed that much. The nasal, you're petrified by bleed because that's a huge amount of bleed that happens there. Strange reasons, it doesn't bleed as much. However, if you don't use a snare, if you try to just pull it off with a cryo or something, the bleeding can be a little disconcerting, especially in this case, when already the patient was having a lot of COPD and severe PAH. I think even a little bit of a bleed is not a good idea. However, we would usually do it even if the rigid is not possible. You can even do it with an LMA. We've done one with a supra and an infra, glottic rhinosporidio in the same thing. We use the LMA and remove the small growths just above the vocal cord, and then take a rigid and then take care of the other things. This technique is also good. Only thing is, as he already said, there is a little room for manipulating a snare, and for snare you'll need even without a thing, an LMA will be ideal for snaring, because the distal end of scope has to run around, and for that you'll need to have a good amount of a play area. For that, this tube might have a little bit of a disconcerting thing, and that's the reason why I think was taken that. Very fascinating thing, and it might look like it just choked the whole airways, but still the patient can breathe because it kind of moves, so it allows the air to go in. So the patient usually presents till last, they'll wait till they get really sick and then they report you, and that's the reason why it's usually difficult, because of the comorbidities also. These are my few points based on thing. We actually wanted to write it because we had 3 cases, and then the 4th one showed up, and so we had to add that and write 4 cases, and the 5th one showed up, and now we just waited for another year and a half. It's only 5, so I think, and especially with Tinku there, because it comes specifically to very south, and so Tinku is there to take care of remaining. So I think I'll have to start writing with the 5 that
I have done a couple of cases, and
yeah, so I think we should collect and put 8 cases, which is a huge thing.
Tomorrow morning, I'm actually going for the 3rd one. I have one more case posted for the.
Okay, so it's specifically it is seen in southern part of Kerala, southern part of Tamil Nadu, and Sri Lanka. However, the largest series of rhinosporidiosis happened from Raipur. A case of 502 cases of rhinosporidiosis, the nasal stuff, and there is not much of a tracheal stuff from Raipur. With that kind of a series, I don't know why they didn't really get a lot of things. It can happen not only in nose and throat and the airways. It can actually go on to involve the skin, the eyes, the lips, and even in penis. So it's a kind of a vague thing. We don't really know why it presents this way and all that, but it's a fascinating thing for an interventional pulmonologist.
And moreover, when it affects the upper airway, in one of the other cases which I did, there was extensive amount of destruction of the upper airway cartilage, like septal erosion, and all those things were there. Compared to the tracheal involvement, there is when the lesions gets affected, affects the upper airway, there is extensive erosion of the cartilages, and it's like a catastrophic condition for the ENT surgeons.
So interesting. I think a very unusual condition, and considering that none of us are from Tamil Nadu, Kerala, Raipur, or Sri Lanka, I leave it open to the audience. Any one final comment from anybody else besides appreciating them?
Before we just wind up, we just have only 2 to 3 questions from our fellow colleagues at my institute, like to the expert panel, if you don't mind, just 2 to 3 questions.
Absolutely. So go ahead.
My question to you is, for a pulmonologist, an interventional pulmonologist would enter early interventional pulmonologist when they go for a stunting. Which stunt would be better? It is a case-based. Which stunt is better?
The stenting. You're talking about tracheobronchial stenting, sir?
Yes, tracheobronchial stenting. Which will be better, a silicone or
a metal?
Self-expanding metallic stent.
Okay, so it depends on the context. It depends on the disease that you're trying to open up. It depends on the life survival of the patient. It depends on what you are comfortable doing. And ultimately, that is the most important thing. And your skills in rigid bronchoscopy. So if you don't have a rigid bronchoscopic skills, then if it's only a flexible, that narrows the choice down to only a metal stent. Metal stent, we use it only in case of patients who don't have a lot of survival thing, which obviously means that it's only in patients who have malignant thing, because if the expected survival is less than, if it's around 6 months or so, then you can do a metal stent. And the reason is because metal stents can have problems after 6 months. So you'll have to deal with a lot of stent related complications, and that is the reason why you use metal stent for cases like malignancy. And if it has to be a benign condition like post-intubation tracheal stenosis and so on, I think you'll need to use a stent that doesn't really injure the native mucosa. And silicone is an inert substance, and that is the reason why it doesn't really cause a lot of problems with the mucosa, and hence silicone stents are always safer stents because it can be removed easily without any causing any damage. However, putting a silicone stent in and taking the silicone stent out requires rigid skills. And so the choice of stent would obviously depend on multiple factors. It's not a single factor that you'll again, it depends on whether you want to put a straight stent or a wide stent. It depends on where the critical narrowing is and so on. So I think the choice depends on multiple factors. A straight answer is if you don't have rigid setup, then it narrows down only to a self-expanding metal stent. And even that, you'll have to be very careful because you can put the stent in, but removing the stent is for any reason that you have to do it. If it's a SEMS, then you'll need a rigid scale again. So these are the things that you'll have to consider when you choose about tracheobronchial stenting. Thank you.
Thank you, sir.
If we put a silicone stent for a benign tracheal stenosis for a case with a bronchomalacia or a tracheomalacia, when do you really think that you will be confident enough to remove that silicone stent? Something we put in, but we are not very sure whether the bronchomalacia, the tracheomalacia, what has set in has got corrected or not. So when do you think will be the right time to remove that stent?
A question for, I mean, maybe Jamal, you want to take it or?
I mean, benign silicone stent for what? For benign stenosis?
Let us assume we have a case of tuberculosis, tracheobronchomalacia. We have put in a silicone stent. So when are we really confident enough to say that the stenosis would have got recovered before we can remove that stent?
All right. I mean, I think you remember in one of my slides there, I have one slide on the timing of stent removal in post-TB stenosis. I think it's it's recommended that you remove the silicone stents after 6 to 12 months. I think the longer the better. I think. I mean that's what's stated in the literature. I think the team in South Korea have a lot of experience in post-TB stenosis, and that's their recommendation there. I normally don't put stent in post-TB stenosis unless mitomycin doesn't work, or I only put a silicone stent if there is significant Malaysia actually. But in terms of timing, when is it safe to remove a silicone stent? In my opinion, it's between 6 months to 12 months. I think the longer the better. But obviously, when the silicone stent is kept for too long, then it creates problem. Then I mean that's I don't think there's any satisfactory answer to this, And I would like to hear from expert from India what you think about silicone stent in post-TB stenosis. I mean that's my answer. 6 months to 12 months at most,
Yeah, sure.
Yeah.
So yeah, if it's a diffuse tracheobronchomalacia, for that, if you're going to put a stent in, then it's a difficult thing. If you put a big wide stent and the patient improves, those are the patients who will improve for surgery. So initially, the group which actually did, this is Grillo's group, which actually did a wide stent for a diffuse tracheobronchomalacia, it only showed that if the patient improves with a big wide stent, the patient will have a very good response to his surgery. And Grillo was that kind of a surgery. All these tracheoplasty and so on. So a wide stent for a diffuse tracheobronchomalacia, the only indication was to see whether this patient will improve with the surgery. If the patient doesn't improve with a wide stent, the patient will not improve with the surgery and they will not do a surgery. But having a huge wide stent inside a gentleman with a tracheobronchomalacia is always a problem because they'll have a lot of stent-related problems. So that's not a great idea. We usually use exhaust all other options, including NIV, and then if the patient doesn't tolerate, only then are we going to use it. Whereas if it's a localized bronchomalacia or a tracheomalacia following a bronchostenosis, tracheal stenosis in pits, the pits usually the literature that they came from the European group based on 52 cases is that after 18 months you remove it, and once you remove it and the patient gets better, 30% of them will not require a stent again. If there is a problem again at that point, we'll have to look at surgery as an option. If the patient cannot have a surgery, then unfortunately, that silicone stent remains there for life. But tuberculous bronchostenosis along with the bronchomalacia, it's very, very unlikely that these things are going to recover. And that's why I agree with Dr. Jamal. We would hesitate to put in a stent. And if you have to put in a stent, it's usually the problem with tuberculous bronchostenosis. There can be a lot of stent-related complications. You can also have a stent which is buried with a significant bronchostenosis before and after. And there are a lot of complications. it's orificial stenosis and so on. So I think we'll have to be really careful before we try to put any foreign body. So stent has to be really thought about, before putting in a condition like a bronchomalacia where you might have to put in. And I would like to hear from Rajiv and Ravi also.
Yeah, but I agree with you entirely. I mean, we are very wary of putting any stents in these post-tubercular patients because they can actually completely misbehave with the stents. They can have all kinds of. You may add on to their problems by putting stents. So we have tried to manage with balloon dilatation if possible, and we have tried to manage with NIV at home if possible. But I am very wary of putting a stent in these patients because more or less by putting a stent in these patients, unless it's very localized, as you said. But if it's a multiple areas of stenosis and if there's malacia along with it, then I think they are best treated conservatively because putting a stent may actually add to their problems.
One last comment from our own Dr. Ravindra Mehta, sir, like before we call it off a day.
Yeah, so tracheobronchomalacia has been what was that new kid on the block, I think a decade and a half ago when it became very exciting. It's very common. COPD patients, long-term steroid patients and so on and so forth. The debulking cough, it's actually causing functional impairment. And that's when the need for either intervention, first whether to intervene or no, the non-invasive ventilation paradigms, and then should we get into stentology and so on and so forth. As Pattabi pointed out, it's extremely challenging to use an Indian mythology word. It's an Abhimanyu thing. When you enter, you have to have an exit plan. And the exit plan, which came out from the people who came out from, the original guys from Boston who described it, was basically do a functional status, put a stent. If they improve, take out the stent, do a tracheoplasty or tracheobronchioplasty with a Marlex mesh. That did not stand the test of time because long-term outcomes have been concerning. Plus, the ability to replicate that tracheoplasty. It's a long, difficult, technically challenging surgery. Originally, postulated by a gentleman called Simon Ashiku, and then it has not really, picked up in several parts of the world. So currently, role of this basically, if it is a reversible cause, you expect an exit strategy. You may do it, but just doing it for a diffuse COPD because you saw one wall kissing the other as a measure long term, probably is not going to work at all. So I think that is the nuts and bolts of the whole thing. And Vish, I think if you are you going to summarize the whole thing, or do you want me to?
Sir, from you, like you will be the.
This has been a lovely meeting. It has, as Rajiv pointed out very nicely, it is a breath of fresh air. And intervention pulmonology is about fresh air in the midst of these, infested COVID times when we're seeing city on city, going under the onslaught of COVID. It started off with with a nice introduction by the Yashoda CEO. And Vish, it's been remarkable that you spearheaded this nice venture and managed to get all of us together for this period of time, and we've all enjoyed it. An excellent lecture by Urve, putting things into perspective, where he tells us it's not about the gizmos anymore. It's about what you do, how you do, and how you ultimately have patient outcomes. Jamal then goes on to describe the benign spectrum, and then of course the cherry on top of the cake, these lovely litany of 5 cases which all of you have presented, right from Hari, Vish, Tinku, Bala, and the last case also, which really has put things into perspective. And we've had a lovely discussion, good teaching points. I think besides the audience, all of us have learned. So we thank you for getting this forum together. We thank you for getting a meaningful discussion. And of course, excellent cases which you could never imagine in these COVID times could be presented as a tremendous learning and enjoyable experience. Thank you so much.